I want to start with this latest news on AstraZeneca and the vaccine efficacy there. It's on average, as Anjali was describing for everyone, roughly 70%. This is a lot lower, of course, than what we've heard from Pfizer, from what we've heard from Moderna, which is roughly 95% across them both. I mean, you are a doctor here. For someone like myself, I think, okay, well, that means the vaccine just isn't as good. I wouldn't want that vaccine at all. Is that true? Does that make sense? Or, is it like once you reach a certain threshold, it's okay, it's good to take?
Yeah, thanks, Kristen, for having me on the show. So we have some great news, right, in terms of projected vaccine effectiveness. We're seeing numbers as high as 95% efficacy, when Dr. Fauci said he would be happy at 75%, and the FDA said they would be happy with 60%. And this is 8 months later, right? And for reference, pre-pandemic, 8 years would have been considered speedy in terms of developing these vaccines. The Pfizer vaccine is showing 95% efficacy in about 44,000 participants. It needs to be kept really, really cold, like a deep freezer, and it's good for 5 days. The company has actually created its own GPS-tracked coolers filled with dry ice to distribute it. But pharmacies and doctors' offices don't tend to have the types of freezers to store these. And the Moderna vaccine is showing 94.5% efficacy with about 30,000 study participants. It needs a freezer too, but one that most medical offices. This vaccine is good for up to 30 days. And most recently, AstraZeneca announced that its vaccine had a combined efficacy of 70% on an interim analysis. So they're the earliest of all the studies, and this study involves 12,000 participants currently. This data is combining two different dosing regimens, with one regimen that has 90% efficacy and another that has 62%. The 90% efficacy was shown when participants took half a dose initially and then took the full dose some weeks later. And the phase 3 trials are ongoing in the US, and they may be shifting to this dose, so their data is still very early and could change. The benefits, though, with this vaccine is that it's an older technology, so it can manufacture much more in a smaller amount of time. In fact, AstraZeneca is promising to make more within the next year than Pfizer and Moderna combined. It also can be kept at normal fridge temperatures, making it more accessible in both developed and developing countries.
Sorry, doctor, I was totally muted.
I was like, I could see your mouth
being in the work from home life. So talk to me then. I know that we have to distribute this vaccine essentially to 300 plus million people inside the United States. So I know you just ran through some of the stats, some of the data for these vaccines. Is a 70% efficacy rate still good enough then to distribute to folks? I know that you mentioned that Dr. Fauci said he would be happy with a 75%. And I know when it comes to AstraZeneca, in some of their trials, they actually were able to hit as high as 90%, depending on how they distributed the vaccine. Just wondering if you had the AstraZeneca vaccine in your hands, right now, would you say, okay, you know what, even with this average rate of 70%, this is still great enough to roll out to folks?
And so that's where I think like the different phases and also looking at like what has worked so far is going to come into play, because they've done a few different modalities in terms of dosages. But when they look at that specific dosing of doing an initial half dose and then another full dose a few weeks later, that's where they're really seeing the 90% efficacy. So I'd see that's where we kind of go in terms of getting vaccinations done. But next steps would be looking into the logistics of distribution. We have got to start looking at anything that can be done to expedite this transition so that Americans can get access to the vaccine when it's out. The first Americans to receive the COVID-19 vaccine could be immunized as early as the second week of December. And initially, that supply is going to be a lot less than the demand. It will be up to the states to define the high-risk groups to first receive that vaccine. So this could include frontline staff, at-risk individuals, elderly, nursing home patients. But by the time the general public gets a hold of it, it's probably going to be springtime. So to get to that goal of 70% vaccinated, it will be summertime at the least. And it's important to note that we need vaccination and not just vaccines. And health departments have limited staff, so they will have to figure out how to ramp up their staffing to administer vaccines and keep track of who's receiving them. And if we go down kind of the AstraZeneca route, where most of these vaccines are going to require 2 doses, so it's not just a one and done situation, it's going to be a massive public health undertaking to make this a reality.
Let's switch now from the vaccine to the antibody treatment from Regeneron. It's the first to get that emergency use authorization, which for everyone at home essentially means that it hasn't gone through all of the steps, all of the rigor, for example, from the FDA that they would normally do in normal times before they roll a treatment like this out. Are there any question marks, any dose of skepticism in your head before taking something like this? Or do you think that if someone were to come into an emergency room and has coronavirus and has to have treatment, that they're saying that they should probably take it, and that it would be better for them to take this treatment than to go without?
Right. And I think that's where it gets back to looking at the data. It's one of the experimental drugs that President Trump received while he was battling the coronavirus, and it's been approved for emergency use by the FDA. This is the second antibody treatment to win emergency use approval from the FDA. And this treatment combines two antibodies and administers them together by an IV. In a clinical trial of about 800 people, the combination was shown to be significantly reducing virus levels within days of treatment. And the FDA made clear, though, that this drug is only for treatment of mild to moderate COVID-19 in people 12 years and older who are more high risk of developing more severe symptoms. It's not for patients who are hospitalized because of COVID-19, and it's not for patients who require oxygen therapy because of the virus. So you have to look at those kind of uses. The emergency authorization of these antibodies administered together offers health providers another tool for combating the pandemic. So we are excited about that. Both this and the other FDA-approved drug are synthetic versions of human antibodies that mimic the immune system's ability to fight off harmful pathogens. And so what they do is they bind to coronavirus and prevent it from invading cells. And like you said, neither drug has yet gotten full FDA approval, which entails a much more rigorous review and takes a lot longer to complete. On Thursday, the FDA also granted emergency use authorization to baricitinib, which, when used with remdesivir, has been shown to be effective in battling more severe cases of COVID-19, the ones that do require hospitalization or that do require someone to be on a ventilator. Emergency use authorizations are granted during public health emergencies when a treatment could be effective. And people, have gone to asked why the president received this. The CEO of the drug company said that he received a request to access this, and they weighed it very carefully against our established criteria for compassionate use, which is an FDA pathway meant for exceptional circumstances.
So this is really important information that you're sharing with us, and I'm glad, because I didn't know all of those full details there, at least when it comes to the treatment. I want to ask you now about the holiday. I think it's something that everyone is thinking about, Thanksgiving being this week, being able to see their family, being able to see their friends. Now, this is something that folks are saying, frankly, we really should not be doing right now. Wondering, as you're seeing it, what are you anticipating? Again, you're a professor of emergency medicine, so a lot of these folks probably would be coming in through the emergency room if they are experiencing trouble from the virus. What are you anticipating, and what are your fellow physicians anticipating in, let's say, 3 weeks from now, after we have this holiday? People probably going to be out there flouting a lot of the rules, because we've seen it happen throughout the summer. And I know that coronavirus fatigue is at an all-time high. What are you guys worried about and anticipating the most for about a month from now?
Yeah. So on Thursday, the CDC recommended against Thanksgiving travel by air and train, right? Despite officials cautioning against it, airports across the nation saw some of the highest numbers to date. I mean, just on Friday, security agents screened over 1 million passengers and then another million on Saturday. The CDC also says that most COVID infections are spread by people with no symptoms. And the weather is colder, so people are staying indoors. And as we know, viruses love to spread in these type of settings. And this is why our traditional viral seasons, like the flu annually, tends to be in winter months and not so much in summer. So it makes sense that the CDC is recommending against indoor gatherings with individuals outside of your household. Now, there are alternatives. They could include small gatherings by the outdoors, which I mean no more than 10 people at a time. You could get, and sorry, my light went out, individually packaged food items as well, and using video modalities such as Zoom or FaceTime to see your loved ones. Many have said video chatting during the pandemic has helped them stay in touch with friends and family members who they otherwise wouldn't see. And I'm going to miss our annual Thanksgiving traditions, but I also want to be able to enjoy our traditions next Thanksgiving and for many Thanksgivings to come. So we'll have to pass. In terms of your question, for what we're going to see in Texas, I mean, the ICUs are being pushed to their limits. In Odessa, Texas, 35 to 45% of people getting tested are testing positive for COVID-19. Hospitals are sending patients with hypoxia or low blood oxygen home with oxygen tanks, something that could usually get you admitted to the hospital. But right now, there's just no space in the hospital for those patients. In El Paso, Texas, 1 in every 24 people has COVID-19. El Paso has almost 50,000 new COVID infections in the past 5 weeks. Hospitals have been overwhelmed, and federal and state agencies have rushed additional medical personnel there. From more than 50 COVID deaths, with another 450 under investigation. And deaths have mounted so rapidly that at least 9 mobile morgues are storing bodies there. Yeah. And I say, yes, we're frontlines in the hospital, but to the public who is watching, you guys are frontlines as well. When you go to the grocery store, you go out, wear a mask, practice hand hygiene, keep your distance from others. Please help stop the spread.
This news, I personally, I'm not a doctor, but it sounds good to me. What about you in the medical profession? Is it truly the kind of thing where we can start to breathe a sigh of relief?
We will be able to breathe a sigh of relief, but not quite yet, because you have to remember that these vaccines are not going to be something that are going to be available for the general public until well into 2021. And the Regeneron monoclonal antibody, as well as the Lilly antibody, these are not game changers. These are going to be marginal improvements to our ability to keep people out of the hospital. So we still have a lot of hard work to do these next couple of weeks as we get into the Thanksgiving holiday, as we worry about hospitals going near crisis capacity.
Dr. Adalja, talking about hospitals going towards crisis capacity, we had hospitalizations hitting a record high for the 13th day in a row. How big of a help is the FDA approving emergency use of Regeneron, just in terms of giving hospitals another option or a viable option here as they're just overwhelmed with patients? I mean, will it really help them get patients out the door?
No, this is a drug that you don't want to give to someone that's in the hospital. You have to give it early. So that's the problem with the Regeneron drug and the Lilly drug. You have to identify people quickly before they require hospitalization. And then this is an infusion. It takes an hour to give, and an hour you have to watch the person to make sure that there's not side effects. You've got to find an infusion center to give this drug at. So it's not something that has an easy concept of operations. And many hospitals don't have the equipment to be able to do this, because you can't put them in the normal infusion center where cancer patients are, because these patients have COVID. So there's an infection control risk. So although these are great milestones, these drugs, it's going to take some time to actually have an impact on how the hospitalization rates fare, because ideally you give this to people to prevent them from going to the hospital. So you've got to catch them somehow soon after their test result is positive. And that's something that's very hard to do. And I think we're going to have challenges all around the country to deliver these drugs.
You could see those challenges right here in New York City. You can see it across the country, but there were lines to get your COVID test around the block in certain parts of the 5 boroughs. And it boils down to the ability to get tested. What are you seeing? Is there going to be improvement? Was this a holiday rush of people defying the CDC and planning to travel? What do you think?
There definitely has been a holiday rush, but this is just more of the same problem that we've seen since the beginning of this pandemic, that we still have a major problem with outpatient testing, where there are long lines, where there are turnaround time delays that maybe are 4 or 5 days in duration, which make the test actually completely useless for people to use for contact tracing or to guide their actions. I do think that this is something that we're going to probably see some movement on as we move into the new year, where home tests might become something of a possibility, because people will be able to use these to guide their actions, maybe brush their teeth and take a home test. And I think there is a lot of effort to put these into place.
All right. Dr. Amish Adalja is the senior scholar at Johns Hopkins Center for Health Security. All the best to you and your team. Thank you for being here.
Thank you.
We're joined by Dr. Manish Garg. He's an emergency medicine physician and co-founder of the World Academic Council of Emergency Medicine. Dr. Garg, thank you so much for joining us today. I'm going to start on the news about the vaccines, especially since Anjali was giving us some updates there. AstraZeneca, of course, has that average efficacy rate of roughly 70%, and they're trying to get it to around 90%, which would be more in line with what we've seen from Pfizer and Moderna. They both stand at about 95%. So that essentially would mean we have 3 different kinds of a vaccine for coronavirus. I guess I'm wondering, especially as folks are talking about all of the hurdles and all of the complications that could come along with distribution, if having 3 different kinds of vaccines from 3 different companies makes it a little bit easier? Does that reduce any kind of worries that doctors and folks might have for vaccine distribution?
Well, thank you, Kristen, and I want to wish you an early happy Thanksgiving. And I also want to just mention that the views expressed are my own. I think it does actually give us a sense of better security that there are more options, that there isn't just a singular option. Interestingly enough, when they looked at the AstraZeneca vaccine, they found that when they had a half dose as opposed to like the full dose they went from like a low 60% to up around 90%. So with like, 3 vaccines that are up in the 90+% range, that's providing a lot of optimism about its efficacy. Now, but here's the problem is that we really just got snippets. It's kind of like a movie trailer. You just know that you're seeing what their initial reports are, but we still need to look at all of the data and see what's happening so we can know better about how the vaccine is going to work in the general population. But it's promising news.
I want to ask you now also about Regeneron. It began to distribute its antibody treatment today on Tuesday. I always forget what day it is. I don't know about you. I'm wondering how this is going to impact the fight against the pandemic now that we're seeing this, emergency use authorization being able to be applied to this antibody treatment for folks who are, I guess, in the hospital because of this virus.
Right. So this would be another modality for treatment. And for just as a historical context, President Trump received this particular medication in October, and recently Ben Carson received this particular medication. So they are saying with Regeneron that they're going to provide 300,000 doses of this antibody treatment. And they're ready to give 80,000 doses right now and then 100,000 doses afterwards. It's another option in what could help us fight COVID for patients that are coming in. Presently, when we are taking care of patients in the hospitals, we're escalating with different types of oxygen therapy. And then when people come in, then we have some better options for them, like steroids, potentially Regeneron. So this provides at least another potential option. And the founder of this particular medication basically said that if somebody doesn't respond well to the vaccine, this may be an option for them, or if there's somebody who doesn't want to take the vaccine, this potentially could be an option for them. I guess I would, that's certainly possible. And if we're talking about 90 to 95% efficacy with the vaccine, there'll be that 5 to 10% that may not respond to it. But I hope that people don't think that they should just wait and only take the treatment as opposed to do something that would be preventative.
And of course, we are hearing that vaccine is not going to be a walk in the park. Folks might be experiencing some flu-like symptoms after they take it. I want to talk to you now about that 7-day record, the 7-day average, I should say, of 172,000 cases. That is a record that we are seeing in the United States. Almost 12.5 million positive cases in the US right now. That is all according to the Johns Hopkins University tracker. Do you still think that there is a much higher peak up ahead? I know that we don't yet have a vaccine. We keep hearing these good news headlines, but we don't have a vaccine being distributed yet. And if the peak is still way out up ahead, how high do you think that it could possibly get, at least when it comes to those positive case numbers?
It's certainly difficult to know. The one thing that we've learned, Kristen, about this virus is that it's predictably unpredictable. And the challenge for us in healthcare is we're starting to see the upticks. I work at multiple hospitals in New York City, and we're certainly seeing more cases that are present there. We're up at around 2 to 3% now for cases, and usually they set the number or bar around 5% in a particular community before you start really worrying about having to, forgo or start to do lockdown procedures. And I can certainly tell you that the numbers continue to rise. And so we're seeing an increase in number of cases. We're seeing an increase in number of hospitalizations. And with the cold weather, with more people potentially inside, with the fact that we have Thanksgiving and some of the holidays that are coming up, folks may want to kind of go outside their bubble and be inside with other people that could potentially be contaminated. And this all is a recipe for a challenge in the winter time. So we're seeing more cases, and I would say across the country, you're certainly seeing a rise. And this is not surprising to us in the kind of public health and medical field.
Doctor, I'm really glad that you mentioned the holiday coming up. Obviously, Thanksgiving is this Thursday. And I know that we've heard repeatedly doctors, public health officials saying over and over and over again, do not travel to see your family and friends. This is not the year. 2020 is not the time to be trying to gather with your friends around the table for the holidays this year. And yet we are seeing, however, travel numbers are really high. Up over 1 million people were screened by the TSA over the weekend, which is kind of actually a return back to some of the more normal levels that we have seen in pre-pandemic times. I'm wondering what you guys are anticipating or are worried about in perhaps the 2 weeks or 3 weeks after the holiday, or even towards the end of the year, because then we have Christmas coming up on the heels of this holiday.
Right. So we're certainly worried about that. And I think part of the issue here is that there's a heterogeneous messaging from different, sites. Sometimes people don't believe that it's out there or that they could be at risk. There's a number of there's a lot of misinformation out there, Kristen. And so I think it's really important that people observe the practices that we know that work, wearing masks, making sure you're physically distancing from people at least 6 feet, making sure that you're trying to not be in rooms with a number of different people. I think that having people travel as much as they are, and we're seeing those numbers, that's actually very scary for us as physicians. I mean, we've been dealing with this since early March and April, and I can certainly tell you from a lot of my colleagues that it's just been a long haul in terms of taking care of patients, and it's been a little disconcerting to see that the numbers are starting to come up and that we'll have to get ready again for another wave.
Now, doctor, as I mentioned, I just want to remind everyone at home that you are an emergency medicine doctor. So I want to ask you now about hospitalization, because I'm hearing of some hospitals having to essentially move patients in order to accommodate more beds in the ICU and accommodate more patients that might be coming in with COVID-related complications. I'm wondering if you guys, either perhaps in your hospital or just generally across the field, are anticipating perhaps that in the next month or so that hospitals really are going to start getting overwhelmed with the amount of folks that are coming in.
Well, Kristen, some hospitals already are getting overwhelmed. And so there are smaller type hospitals that are reporting, and colleagues are reporting around the country that they are seeing very, very large numbers. I think one of the things that we learned early on in the pandemic after that March and April surge was that we need to be ready. And thankfully, many hospitals have disaster plans. They know exactly what they need to do to increase capacity with the number of beds, know how to stop some services like elective surgeries and procedures, and to be able to open up different areas of the hospital to make sure that they can accommodate the large volumes. If you look at what we did in New York City, the number of hospital beds was thankfully very much increasing at a rate that was commensurate with the COVID surge. And so, it was important that we had the hospital beds, that we had the right amount of ventilators. And thankfully, because we're getting better at treating, hopefully there won't be as many people that will require those ventilators now that we have a better idea of how to manage this disease process. But still, like I said, it's predictably unpredictable. And so we know that there'll be more cases and we need to be ready.
All right, Dr. Manish Garg, emergency medicine physician and co-founder of the World Academic Council of Emergency Medicine. Thank you so much for joining us and bringing us those updates. And of course, have a happy holiday to you as well.
You too. Thank you so much, Kristen.
We want to stick with this, and for more on that, we want to bring in Dr. Payal Patel. She's an infectious disease physician and teaching faculty physician with the University of Michigan. And Dr. Patel, it's great to have you on the program. Let's just start with what we just heard Anjali end on, and that, of course, is the Thanksgiving holiday travel numbers. TSA saying that just around 3 million people traveled from Friday through Sunday. When you take a look at those types of numbers, are we going to be in a more serious situation this time next week because of the number of people that are traveling for the holiday weekend?
Yeah, I mean, I think looking at the entire country, every state is already kind of in dire straits. And that was one of the reasons that public health officials were hoping that more Americans would try to stay home this holiday season. I mean, I think when we think about travel for the holidays, it's not just going through the airport, right? It's going to someone else's house, often eating with your mask off, indoors for hours with family often with alcohol and just, trying to have a good time, that's when you forget about a lot of the precautions that we all have been taking. And many people haven't quarantined for 14 days or so before traveling. So we're really worried in the medicine community that we are going to continue to see cases rising up.
Dr. Patel, I think a lot of us would benefit from a kind of refresher of that which we already know, given what the CDC is considering with self-quarantine guidelines, potential changes. But that refresher for us, what if you are exposed to coronavirus and you do develop illness? Because a lot of people won't even know they've ever had it, right? What percentage will never know they've never had it? And for those who do develop something, what is the period when you start to, is it 2, 3, 4 days when you'll start to see symptoms?
Yeah, that's a great question. How many people won't know they ever had it? It's actually unknown still at this point because many of those people haven't ever been tested, right? So I would say one way to think about it is once you know that you've been exposed to someone, let's say you've gone to a restaurant and you get a call from that restaurant that someone was, near you that had coronavirus, or someone in your office has coronavirus. You should assume that you've been exposed and that you may be asymptomatic. Try to get tested and follow whatever the quarantine guidelines are at the moment. We know that they might be changing soon, but it's easy as Googling CDC quarantine. And that would be the best way to try to protect yourself from spreading it to others that are around you and protecting those that you love.
Dr. Patel, are you at all concerned just about the CDC potentially shortening the amount of time that someone needs to quarantine after a potential exposure, just in terms of the fact that, it's been 14 days. You can make the argument as to why they're doing it. They're trying to, entice more people to abide by those guidelines. But then, of course, you could take the other side and say that you could potentially be going out when you're still contagious and spreading the disease to more people.
I think that the most important thing at this point would be people trying to follow any of the guidelines. And so when we think about it from the infection standpoint, each day that you quarantine, whether it's 7, 8, 9, 10, each day that you quarantine will actually increase your chances of not spreading it. So that's how I think of it. So if you can even do 7 versus 10, 11 versus 9, every day you're actually helping to make sure that we're not spreading the virus further than it's already been spread. In the hospital, we're already out of beds in many states. And so if that is one small thing that the public can do, I think that would really help.
One quick last question for you, Dr. Patel, and I'm on this refresher course kind of thing. The survivability, what we're seeing of people who do go into hospital, that's improved dramatically over the last 8 months. Is that correct? Do you know a statistic? Is there a number as to those who unfortunately do go into the hospital will be able to leave the hospital?
I don't have a statistic off the top of my head, but I do agree the more we've learned about the virus and kind of the more that mask wearing has become the norm in many cities, we think that people are getting a little less sick. That doesn't mean that people aren't still getting hospitalized. And so let's say you have a heart attack or something else like that. If the hospital is full and you need to go in for non-COVID reasons, you want that bed to be there for you in case you have something else that happens.
Dr. Patel, we really appreciate you taking the time. We know you're extremely busy right now. Thanks so much for joining us. We look forward to having you back soon.
It is, of course, Thanksgiving Eve here in the United States. This as the spread of coronavirus continues across the country, COVID-related hospitalizations currently at a record high. And we have seen guidance from the CDC and others on how Americans should be thinking about staying safe this holiday season. Joining us now to discuss is Dr. Robert Redfield. He is the director of the Centers for Disease Control and Prevention. We're also joined by Yahoo Finance's Anjali Kemlani. Dr. Redfield, thanks so much for joining the program today. I'd love to begin by talking about the holiday, the guidance that the CDC has put out, and what you are hoping Americans will do over the coming days to help as best we can stop the spread of COVID right now.
Yeah, Miles, it's really important because, as you know, we're in a significant surge right now across the country. And it is just so important that the American public redouble their efforts to be vigilant on the key mitigation steps that we do know work. For example, masks. We know they work not only to protect you from infecting others, but also to to protect you from getting infected, hand washing, social distancing, really being smart about crowds, being really select about activities indoor, try to maximize ventilation, do as much as you can outdoor. And this is why we advise the American public, knowing that, this is an important holiday, that we really advise people to reconsider about traveling, reconsider about trying to limit themselves to small gatherings of individuals that actually live in the same home. Because right now, the major way this virus is transmitting around our nation is no longer the public square. It really is these household gatherings. And we have many, 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 many counties now, even in rural areas, that are in what we call the red zone. So we're trying to really escalate our message for individuals to realize we can make a difference. Kansas recently did a study where there was a mask mandate, and some counties opted out of it. Some counties opted in. The counties that opted in had about a 6% decrease in cases per 100,000 in the observation period over approximately 6 weeks. The counties that decided to opt out of that mitigation step had over 100% increase in the cases. So each of these mitigation steps that we've recommended really do work. I know it's difficult. I have a large family, but I think this is a Thanksgiving, and this is a religious holiday season that we're going to have in December, where I think it's much more prudent to be circumspect about travel, about gathering with individuals for meals that aren't part of your own household, being vigilant about wearing masks, hand washing, and being vigilant about being smart about how you put yourself at risk in crowds.
Dr. Redfield, Anjali here, good to talk to you again. I know that you've addressed this already in terms of small gatherings, and there have been some reports that say that it isn't necessarily so. I wonder if you could explain, are there details involved in your saying that small gatherings do contribute to transmission, such as ventilation or wearing masks even when multiple people are indoors? Are there steps that can be taken if someone wants to gather?
Yeah, I think you raised some important points. Clearly, wearing masks is important from everyone in the gathering. Clearly, maximizing ventilation is important. Clearly, maximizing social distancing is important. A number of people who are having these gatherings are opting to have them outside rather than inside. Even though it's cold with heaters. My wife and I celebrated her birthday last night in a small outside table where there was really only one other couple in the outside area, probably separated by 20 feet. And yeah, we kept our coats on, and yeah, it was cold. But these are the type of things we're really asking people to do. Don't let down your guard. And many people do when they're among family members and you're having a celebration meal together. You're taking off your mask. You're socializing in a close space. This is what we're asking people. If they do these gatherings, please wear your mask. Please social distance. Please try to maximize ventilation. Consider doing it outside if it's at all possible. If not, open the windows and doors to maximize ventilation. Because the reality is, when you look at this surge we're having across the country, it's not like the spring when the surge was in major cities, New York, Detroit, New Orleans, Los Angeles. This surge is really throughout the counties. We have thousands and thousands of counties now, even in rural states like North Dakota, Wyoming, Montana, Idaho, where they have very low population densities, but they're having very high infection rates. And again, it is because this virus is moving silently. It's a silent epidemic. Largely individuals 15 to say 35, asymptomatic, are transmitting this virus. So I know there are some individuals that try to suggest that maybe small gatherings and household gatherings aren't driving this. I think we're confident that this is where the pandemic is centered now. There's been much more, I think, effective attention to the public square, where people are being much more careful. I do think people have a tendency to be less careful when they're in these small household gatherings in their own home. So we've really made it clear when we're talking about having a household gathering, we're really trying to tell you to limit it to the people that actually live in that household, sleep in that household. And when you're bringing other individuals in, then you really need to be vigilant with, like what you said, with the mass social distancing, increased ventilation, and trying to be smart about the interactions that you do have.
Absolutely. Moving on to, we've seen, a lot of travel as well. And I know that the CDC or individuals from the CDC conducted a study about travel-related spread. And it seems like the results of that have led to consideration of a change for the quarantine period down to 7 or 10 days. I wonder if you could elaborate on that and sort of what the thought process behind this change is.
Well, I can tell you we've always tried to use, as you know, CDC is not an opinion organization. We're a science-based data organization. And the data that we do have then defines our recommendations. And as you know, the best data that we had was that individuals, we would isolate or quarantine for 14 days because people that have been exposed could actually become positive for virus somewhere between that. Even if you cut it originally at 10 days, you may miss some individuals. We've continued to study this aggressively in a variety of different settings. And that data is now being critically reviewed and put together. And based on that data, I anticipate we're going to revise our recommendations. So we're constantly doing more and more research to try to validate our recommendations and see if they can be improved. And I do anticipate that we will come out with new recommendations that look at a shorter period of quarantine and even a shorter period of quarantine where you would test out of quarantine. I don't want to get ahead of the recommendations. I know there's been some talk in the press about it, but I do expect that in the next week or so, that data will be completely analyzed and then the recommendations will be made based on that data.
Doctor, in terms of a vaccine, how severe do you think the side effects will be to a COVID-19 vaccine, and what should the American public expect when they do take this vaccine?
Yeah, I think it's important. I've seen there's a lot of reporting on this recently. Obviously, as the FDA finishes their formal review and issues the EUA, there'll be comprehensive data there related to safety, adverse reactions, and side effects. And that information obviously will be transparently presented to the American public. Our advisory committee on immunization practices will put that together along with the recommendations that come from the FDA. I anticipate so far that this is a relatively safe vaccine. We haven't seen many serious adverse events, as you know. Obviously, there are reactions that we see with many vaccines between injection site soreness and sometimes some systemic symptoms of feeling like you have a flu-like illness. But I think let's wait till the analysis is complete and those data will be presented in a transparent way to the American people. I will say that for those people that are at risk for a serious outcome, or those people that are at risk for being infected and being a silent spreader to somebody else, I think this vaccine is really going to be a game changer for us in this pandemic. We're hopeful that the American public will embrace it. Obviously, we're going to present the information as clearly and transparently to the American public as we can.
Dr. Redfield, finally, if I may, sir, you sound a little weary, and I think we're all a little weary, but you especially, I mean, this advice that the CDC and other health professionals have been giving for so many months now about wearing masks and social distancing is not being taken to heart by all Americans, or else we still wouldn't be seeing this spread. As we look ahead to future pandemics and to whomever your successor at the CDC might be, what advice would you give them? What is sort of the central lesson we have perhaps learned throughout the course of this pandemic that we can pass on and apply in the next situation?
Well, it's an important question. I know when I finish my tour of duty, reflecting on it substantially, because I think that's really the key. What lessons were learned so that you can kind of articulate and share that. I think for me, if there's any disappointment, is that we didn't come together, I think, effectively as a nation and really hone in and reinforce a central message. Masks work. There's no question about it. The science is clear. And yet, I'm sure you can have 10 people get on your show and tell you that masks don't work. And this is difficult, when the American public is trying to understand, what message do I accept? I'm trying to, we have tons of evidence. Some of it is, when you're getting a new pathogen, as we did. I mean, when it first came, we were looking at this like flu. And so people were assuming that the real target that we had to focus on was symptomatic illness. And then once we had symptomatic illness, symptomatically ill patients should then wear masks. And then all of a sudden we learn, wait a minute, this virus isn't like flu. It's not like SARS. This virus actually transmits really well asymptomatically. And then that's what led us to understand that we needed to get source control. And so we needed everyone to wear a mask because we didn't know who was infected and who wasn't. And I think that transition of message from January and February to April 3rd, when we issued our mask guidance, a lot of people exploited that and basically put doubt in whether masks work or don't mask. Sadly, that issue became politicized. So what I would say is the biggest lesson that I've learned, it's how critical it is to have unity in message, unity in message, unity in message. And you're right, we keep repeating the same message, but I'm hopeful, particularly now as people see what's happening, the spike in cases. We had over 1 million cases in a week, last week. Now getting back up to 1,500, 1,700, 1,900 deaths a day. My hope is that people will take that message again and realize now, particularly because we have a vaccine that is going to be available starting in a couple of weeks, and then over the next months ahead, between now and probably the end of the second quarter, beginning of the third quarter of 2021, the American public is going to have the benefit of being vaccinated, and we're going to be able to put this pandemic behind us. So it's so important now not to be in the last group that ends up with a serious fatal outcome, because, my 8-year-old child who works in a hospital comes home and inadvertently infects me and my wife. I think we have to be vigilant now, not give up on it. But to me, that's the biggest lesson is if we had unity as a nation of message, using the tools that we have, hopefully we can still get there for December and January and February and sort of rally around the reality that the vaccines are here. There's a light at the end of the tunnel. The cavalry's coming. We're going to get the vulnerable vaccinated. We're going to make sure we start to confront this pandemic and really put it behind us. And then we can turn our attention to helping the rest of the world, particularly resource-limited areas, begin to get this pandemic under control for them also.
Dr. Argerfield, a final question on that vaccine distribution. I know that the advisory committee did recommend that essential workers get vaccinated before the elderly, and it seemed to make a lot of health equity advocates very happy. But then we heard Secretary Azar yesterday say that it was really up to the states. Where do you stand on this, and what can we expect in terms of actual distribution?
Well, we're still in discussions, as you know, to make the final recommendations that we will have from CDC. What has been determined, as you know, and as Secretary Azar and Operation Warp Speed have probably articulated the other day, is there is a distribution to each of the 64 jurisdictions that is going to be done based on the amount of vaccine we have, based on population size. But the micro distribution, once that vaccine is within those states, clearly CDC is going to give clear guidance. And as you mentioned, whether it's healthcare workers, first responders, whether it's the most vulnerable, whether it's strategic in trying to maintain healthcare resilience, obviously individuals in nursing homes. Those final recommendations will be forthcoming shortly. But at the end of the day, the vaccine is going to be delivered to these jurisdictions. And what I call the micro distribution plan will be executed by the individual states based on how they finally decide to do it. CDC sent out a playbook back in July to have each jurisdiction, 64 jurisdictions, start to figure out how would they distribute this vaccine to their population. They worked on them. They completed them by late September, early October. We went back and forth to make sure there weren't any gaps. And so each of these jurisdictions do have a plan. That plan may be modified based on the final recommendations from CDC. But ultimately, the decision on exactly how to distribute this vaccine will ultimately be made by the individual states, as Secretary Azar said the other day. But we will be giving our recommendations, how we believe this vaccine should be distributed at this moment. And I expect those to be forthcoming shortly.
All right, Dr. Robert Redfield, the director of the CDC. Sir, you've been very generous with your time this morning. We really appreciate you joining the program. Have a great Thanksgiving.
Yeah, God bless you all. Be safe. Thank you.
That's Dr. Stella Zappo from Boat Health. She's the co-founder there. It's a New York City-based HIV primary care unit. She's a physician. So, Dr. Zappo, I want to ask you about people that gathered over Thanksgiving. And there were many people that decided to do that with their families. And Dr. Birx has said that Americans who gathered for Thanksgiving should assume they're infected. Do you think that that's a good starting point? Do you think that makes sense?
I think it does make sense. So when we talk about gathering, there's a couple of different ways that we're thinking about it. There's the gathering that can happen where you are outside, distanced and masked up, which is fairly safe. And then there's the gathering that we believe has happened during Thanksgiving where you were inside the house without a mask, eating that delicious turkey and whatever else you had. And in that case, because you were probably with individuals who were not within your household, in other words, people that you sleep in the same house with, right? You brought in new individuals because you were in a house with different individuals who may have the virus, and because you were doing an activity like eating and talking where you can spread, droplets, there is a chance that if anyone in any of those gatherings had it, then other individuals have been infected. So I think it's a fair thing to think about the kind of gathering that you had and then kind of rank your risk from there.
Dr. Anjali here, looking at what we see, of the gatherings and of the anticipated, rise in numbers, as it stands right now, can we take away anything from, decreasing positivity rates right now, or is it still sort of a wait and see for the next 2 weeks?
Yeah, a lot of our models at this point have had enough information. I'm based in New York, and so in March, when everything started to happen with COVID really spreading through this country, it started in New York, and our models were just being primed then. So we had no idea really of what to expect. At this point, we have enough, unfortunately, real world experience, and we've done enough modeling to kind of have a sense of what happens if you place into the model kind of high risk behaviors. So that's crowd gathering, being maskless, et cetera. What happens anywhere from 7 to 10 to 14 days out. And we know that that's just an exponential kind of increase of a line. So that's part of the reason why you hear everyone sounding the alarm, everyone from your local clinicians, public health experts, to Fauci and Birx and everyone else sounding the alarm, is because there's a real sense that if we project the number of individuals who've gotten together in these unsafe, kind of settings has happened, then we know that in about 2 weeks, we're going to see those numbers surging. And the concern is at this point, hospitals are getting towards capacity. So adding more to an already full bucket is really something that we're very, very scared of.
Doctor, I was curious, the lines we saw nationwide and in New York City to get tested before Thanksgiving, a lot of people said that's because people were planning to travel. Do we have the testing infrastructure in place? Because the key seems to be continual testing on a rapid basis where you get the results quick enough so you can know I'm not going anywhere.
Yeah, and it's so unfortunate because this is what people talk about when they talk about how, we've been in this pandemic now for 8-9 months and we should have had some things that should already be happening now. This is what we mean by the lost time, right? At this point, we should have it so that individuals can get tested very frequently. And it's not because testing is a solution that's going to solve everything, but it's exactly as you say, testing allows us to know what's happening to you at a point in time. So, again, in New York, if you went down the street and any of these areas around the urgent care centers, there were lines around the block of people getting tested and kind of falsely thinking, well, if I test negative, I can go home, hang out, and I'll be fine, right? Well, if you test negative, and let's say you were exposed to COVID, within that kind of incubation period, your test might be negative, but you could still be brewing the virus. And so you almost need a system within our country, which is what we're hoping we'll get with a new administration and new heads kind of thinking about this, where you have much more rapid testing. Almost think about what we saw with the sports leagues, with the NBA, where they were testing folks really, really frequently. Unless you're doing that level of testing, a one-time point in time test to tell you if you can travel or not doesn't really answer the question of, are you safe over the next couple of days as well. So it offers us, unfortunately, a false sense of security. And I will say, we're happy to see that people are at least taking that precaution, making sure they're not traveling if they're sick. But it isn't the kind of Band-Aid that I think many people believe it to be.
Doctor, what do you think really is the strategy that needs to be taken on? I know there are a lot of people really pushing for rapid testing and frustrated that other countries have been able to get more tests done, whether or not they're as accurate has been the problem. So there's sort of two schools of thought, I think. One is get the test done no matter what, and the other is just roll out the ones that are near perfect. Where do you stand on that? What do you think we should be following for the next administration?
Yeah, I think that, and as an HIV doctor, I kind of bring the HIV lens to a lot of these different epidemics and pandemics that we try to control. With HIV, we focused on prevention and treatment. And so the treatment angle right now, you're hearing all the alarms because our hospitals are full. So we're afraid we won't be able to treat adequately. And so preventing people from getting sick is so key. And that prevention really happens with behaviors, unfortunately, rather than testing. So the behaviors that we're recommending have been from the beginning socially distancing and definitely wearing masks, especially if you have to be indoors and inside with people outside of your household. And where testing then becomes really interesting and helpful is that it allows people to have the kind of information they need to be able to make the actions that they need to happen. So the next administration, I think, is really looking into things like, at-home testing. So you can get a kit that's affordable that you can test yourself before you have to go get online for 2 or 3 hours to figure out, if your PCR will come back in 4 to 6 days, which is what we're seeing in certain areas. So it's definitely testing is part of it, but it's that larger kind of prevention solution that we really need to push, which is mandated masks, as well as, really thinking about how do we prevent people from kind of getting into these crowds where we're seeing the virus continue to spread. I think the modalities of testing that you use, you can definitely play with it. But again, it's just a small part of kind of this whole picture that we really do have to create and invest in to make sure that we can stop the spread.
Dr. Stella Saffo, Vote Health co-founder, thanks so much for joining us.
My pleasure.
Well, I want to continue the conversation that we had started just before the break on the coronavirus vaccine. Moderna, again, is asking for emergency use authorization, which means a vaccine could be rolled out before the new year. We're joined now by Dr. Howard Foreman. He's a Yale professor of diagnostic radiology and public health. Doctor, so starting with this news, Moderna effectively saying that their vaccine is 94% effective, seeking that authorization. So people can start being vaccinated, at least with Moderna's vaccine, before the new year. When do you think, however, that everyone, at least in the United States, will be able to get vaccinated if they want it in this country?
I tend to be on the more optimistic side than a lot of other people, and I think that by early spring, most people will have some degree of access to a vaccine. I'm more concerned about vaccine hesitancy. I'm getting more and more confident that Pfizer, Moderna, and hopefully J&J will all have vaccines available in this country by midwinter. And that they have the capacity to produce sufficient vaccines. Now we're dealing more with the logistics of it and then vaccine hesitancy. And certainly the news from Moderna today helps a lot with hesitancy, because if you tell me that a vaccine has 50% effectiveness and we don't know a lot about long-term side effects of it, I might really have good reason to be hesitant. But if you tell me this vaccine is 94% or 100% effective at preventing severe disease, then I'm able to do a risk-benefit calculation that favors getting the vaccine much more easily.
So, Doctor, two things to pick up there. I'm going to start first with this path to normalcy. At least myself, and I'm sure others are out there probably thinking that this vaccine could be almost like a light switch moment, that once people get it, life is essentially going to be able to return to normal, or at least they hope. What does this path to normalcy really, truly look like, even with this vaccine available?
I think for individuals and individual families, it will be closer to a light switch. Once a unit and family are vaccinated, if we do have confidence that it has 100% protection against severe disease, then that unit can function in a much more normal way and not have to go through a Thanksgiving like we just went through. On the other hand, for society at large, it doesn't get back to normal right away, because we're going to continue to have patients coming into hospitals. We're going to continue to have to worry about our most vulnerable. We're going to continue to have to worry about families where there is incomplete vaccination. So it will not be immediately normal on a population level, but at the individual level, it really has the possibility of changing things very quickly.
Throughout this pandemic, the federal government has repeatedly been criticized for their response to the pandemic, or some would even call it almost a non-response, in the sense that testing, restrictions, lockdowns, even mask mandates, they were not mandated on a national level, but rather were left up to the states to handle and to take care of. Now that we have, Pfizer and Moderna with these vaccines that are set to be rolled out, I'm wondering, from your perspective, you do healthcare policy, you're an expert in that field. Is it going to be necessary that the federal government handle that rollout? Or can this be something that is left up to the states on a state-by-state basis on who to give it this vaccine to and when? I'm wondering your thoughts there on this distribution.
Look, I think the coordination at the federal government is incredibly important. Trying to figure out what demand is going to look like state by state and allowing states to have to compete with one another would only lead to a wild west where some states might get vaccines, some wouldn't, and so on. We must have coordination at the federal level. We must be able to create a marketplace where if a certain state is underusing their vaccines and another state has more demand than supply, that we're able to move those vaccines around. That's something that really does require federal coordination. The federal government must be integral to messaging and having consistent messaging that then trickles down to all leadership at the state level. That has not been happening so far. That will help tremendously with vaccine hesitancy and with getting people over the hump and concerns that they have about what a vaccine will mean. And it's also very important for people to understand what the risks are and what they're not associated with that. All of this requires leadership at both the federal and state level to work together. And the logistics are not a small piece, but I have a lot more faith that between the private sector and the states, that the final mile is being worked on aggressively right now, and that if the federal government can do its coordination piece, the states will be very helpful here. What we saw earlier on this year is we failed to get tests out to the states. We failed to put states in a position to be able to test. That was a huge, huge failure. And then when it came to PPE and ventilators early on, we had no means to coordinate where there was excess supply or excess demand.
Doctor, I want to quickly ask you before we have to end here about the pandemic as we're seeing it. I mentioned a little bit earlier in the show that we have 13.4 million cases. So we're staring 14 million cases right in the eyes right now. And everyone's been talking about who would get the vaccine first. And of course, they're mentioning, the frontline workers, essential workers like doctors, people that are working in healthcare. But of course, as we've seen throughout this pandemic, this virus right now has permeated other segments of the population, just young folks perhaps going to dinner with their friends, or, grandparents who are, seeing their children or their grandchildren. So I want to know from you, while one segment of the population, of course, is going to be getting this vaccine first, I'm wondering, just on a public health perspective, is it still possible that even while we are vaccinating folks in the United States for this virus, still to, in a way, continue to spiral as many folks go out there and perhaps think, hey, a vaccine is out there right now. Time for me to, go and see my friends again. Time for me to go to bars again, restaurants, etc.
Yeah, look, this is the moment where people should be doubling down on protections, because any infection avoided now is a death avoided and not just deferred. It's no longer that I'm putting off the inevitable. I can now save lives by avoiding the spread. So the more that we do right now, the bigger the impact it is. So we should not concede defeat at this point. We must do everything we can to avoid that. What you said about prioritizing who gets vaccinated is also really important. We need to protect the most vulnerable in nursing homes, in facilities where the most vulnerable live and where healthcare workers are delivering care and potentially spreading the virus to them. So there are a lot of strategies, and those are going to be discussed by the CDC this week, and we're looking forward to seeing their recommendations about prioritization.
All right, well, we are going to leave that there. Dr. Howard Foreman, professor of diagnostic radiology, I can't talk today, and public health at Yale. Thank you so much for joining us today.
Thank you. Take care.
Well, let's get to what has been going on with coronavirus cases rising, continuing to rise, although at a slower rate to some extent than we have seen in recent weeks. Hospitalizations, though, do continue to rise as well. And we have seen a lot of concern about staff shortages for people who are caring for those with coronavirus, as well as just hospital staffing generally. We're joined now by Dr. Patricia Pittman. She's George Washington University Director of the Mellon Institute for Health Workforce Equity. Thank you so much, Dr. Pittman, for being here. And this is something that you all have researched and focused on, the staffing flows that we have seen over the course of the pandemic. Talk to me about your findings and what is most notable or remarkable to you.
Well, I mean, I think the first point is precisely the one that you made, and thanks for giving me the opportunity to talk about this, which is that the issue of expanding beds is only one part of the problem we're facing. If we don't have staff to provide services at those bedside sites, it's really not that helpful to have additional beds. So, for example, in my home state of Maryland, there are a number of areas where they're planning to expand, have sort of emergency sites with additional beds. But the problem is we don't have the staff to be able to accompany that initiative, so they can't open them. So what we've done at GW is create a tool that allows you to look across different specialists by state to see where we're likely to have the most shortages in the coming month. So we're looking at the projections of hospitalization in relation to the supply in that state. And the news is not good. Basically, we see that in 43 states, we have shortages already of at least one specialist. And in the remaining 7 states, we actually have insufficient number of staff for non-COVID patients. So the issue of staffing for COVID patients, but also we continue to have to provide services to patients that have other kinds of needs. So the situation is very serious at this time.
And Dr. Pittman, throughout the pandemic, we have heard stories of staff burnout. And then, of course, you're going to have a lot of doctors and nurse practitioners and so on getting sick as well. Is this factoring in those dynamics, or is this just a raw, we don't have the bodies, even if everyone shows up all the time and feels great?
So the tool that we've created actually allows you to put in what we call the attrition rate. And we are estimating that there's about a 7% attrition rate across states, but it really varies tremendously, even within states. And so what we've done is preset it at 0 attrition, as if nobody ever not only gets sick, but might not show up for work because they're fearful or because they have to take care of their kids because their kids aren't in school or they have aging parents or whatever the reason may be. There are a lot of people that are not coming to work, or because, as you said, of burnout. So even when you sort of preset this tool at 0 attrition, in other words, assuming that everybody came to work, we're seeing these massive shortages in 43 states. So when you increase the attrition to the levels that we think are actually there, and the user of this tool can actually plug in their own attrition rates, it looks even worse. And there's no question that this issue of burnout and fear, and also just the requirements of being a a mom and needing to stay at home for your kids, is really taking a toll on the workforce, particularly for nurses, which is a predominantly female profession, of course. So even though we may have, in some states for nurses, what appear to be adequate supply, if you look at the maldistribution within the state, and if you look at the issue of attrition, you're likely experiencing even worse shortages.
Doctor, how should hospitals go about addressing these massive shortages?
So hospitals are sort of one level of solutions. It's important to remember that the state government and the federal government can do things too. But speaking to the question specifically of what hospitals can do and are doing, essentially they're flexing their staff. They're thinking about the other inpatient staff that are not in ICUs, that are in acute care units, and sort of repurposing, if you will, those doctors and nurses and support staff for ICU beds. The problem is that when you take people off of those acute beds, you're leaving them unstaffed. So currently, we are continuing to allow what's called elective surgeries, for example, in ORs and other departments. And if you take that staff off of those other departments, you it basically means you can't continue to care for patients that don't have COVID. So it's not an ideal solution, but it's certainly one that has to be used when you're facing shortages. So we're seeing in particular the most severe shortages in the ICU as opposed to just the acute beds.
I think the effect of all of this is clear in terms of patient care, in terms of the effect on workers, as Miles alluded to. What about the sort of economics of the hospital, right? We know that hospitals are already stretched because they are not able to do as many of those more profitable elective surgeries, for example, that fund hospital operations. So what then happens when you have worker shortages on top of that issue?
Well, there are a couple of sort of economic considerations. One is, as we said, this question of elective surgeries, which initially during the pandemic, the federal government had asked hospitals to suspend elective surgery. So there was obviously a huge economic impact there. Currently, they are allowed to proceed with them if they have the staff. So if they don't have the staff, they're obviously having to scale back those services. The other economic factor, though, is that particularly in the case of nurses, we have this phenomenon of what's called per diem staffing agencies that provide nurses sort of to the highest bidder, if you will. And in the early phases of the pandemic, they were really essential in terms of moving particularly nurses across states and taking them to where they were the most needed. At this point, however, because we have sort of the high hospitalization rates in all states, the problem is everyone wants those staffing agencies. And so it's a bidding war. And you may have read in the press today that there are nurses that are basically earning up to $11,000 a week to move around the country with these staffing agencies. The problem is for those hospitals that are least advantaged economically, particularly rural critical access hospitals, that's essentially unaffordable. They basically quadrupled the pricing for hospitals of using these travel agencies. So that's sort of an additional level of economic pressure on hospitals as they seek solutions to these staffing crises.
Wow, that is really fascinating and dismaying for those folks in those rural areas. Doctor, thank you so much for your time and for walking us through these issues. Dr. Patricia Pittman is George Washington University Director of the Mullen Institute for Health workforce equity. We appreciate your time.
Thanks so much for having me.
Let's turn our attention now to the coronavirus pandemic. There are nearly 13.6 million cases in the United States right now, and the death toll has jumped to roughly 269,000 deaths. That's all according to Johns Hopkins University. So let's talk about this and the vaccines that could be available soon with Dr. Hilary Babcock, professor of medicine in the Infectious Diseases Division at Washington University School of Medicine. So doctor, I kind of want to start on where we are and where you think we're going to be, what kind of shape we're going to be in the next, I would say, week and a half or so, especially after this holiday, with the TSA saying on Sunday that they screened over 1 million passengers. That's a number that we have not seen since over 7 months ago. Where do you think we're going to be 2 weeks from now?
Not in a good place is the short answer. We know that the more that people are out in public and are out together, that the risk of transmitting COVID is higher. Numbers across the country are really high already. And so the fact that so many people were moving around the country and getting together with family is definitely going to increase those numbers. So we have been seeing a pretty rapid rise coming up to Thanksgiving. It may be blunted a little bit in the last day or two, but I anticipate that's going to continue to rise over the next couple of weeks.
Now, Pfizer and BioNTech have asked for vaccine approval in Europe. They've already asked for that approval here in the United States. I'm wondering if you think that the light at the end of the tunnel, so to speak, is really fast approaching for the end of this pandemic, not just, of course, here in the United States, but really globally.
So I do think this is really good news that these vaccines are available, that they are coming up for emergency use authorization, that they appear to be so effective. This is all really good news. I do think that it means the light is visible at the end of the tunnel, but I think the end of the tunnel is still a ways off. We do need to get the vaccine into the whole population. We need to get people comfortable with the vaccine and with taking the vaccine so that we can get the majority of the people in the country vaccinated and the majority of the people in other countries vaccinated to really be able to contain this spread. So definitely light at the end of the tunnel, but still really months to go before we're really at that point.
So picking up on that, is there a risk that with this virus that, as people are getting vaccinated, that some folks might say, okay, look, the crisis is over. We have frontline workers being vaccinated. We have the elderly being vaccinated. And people who haven't yet received it, like the younger people, are still going to continue to go out and go to bars and go to restaurants, and they're going to contract and spread it. Or is it really more a sense of there will be herd immunity reached once we get some of those frontline people vaccinated first?
So getting those frontline people vaccinated is really important in order to provide protection for them and to be able to keep their ability to provide care for people who get infected, to be able to keep the economy moving, critical workforce, and the people at highest risk for complications and death should they get COVID. But we really need a herd immunity level of probably 60 to 70% protected in the population as a whole before we can expect to see significant drops in transmission and before we can anticipate seeing these clusters and outbreaks that have been occurring across the country. So I do think there's a risk that people will be like, yay, we have a vaccine, everything goes back to normal tomorrow. It'll be a more gradual process and we'll be able to track case numbers, and as case numbers go down, we can begin to start opening things back up and restarting some of the things that we have given up during this year.
I only have about 30 seconds left with you, Doctor, but I really want to ask you, picking up on that herd immunity piece, how long, if we start rolling out this vaccine as soon as the end of this month, how long before we hit that 60 to 70% of herd immunity?
There are still some unanswered questions that make that hard to answer. So we don't know exactly how many doses will be available, how quickly, and what the distribution capacity is. The problems with our public health infrastructure will continue to make it difficult to get the vaccine out promptly and quickly to all of the people we want to give it to, even when there are doses available. But I think that, by the end of 2021, we should be in hopefully a pretty good place. And we should have a sense of how well it's all going by the summer of next year.
All right. Hopefully, end of 2021. We're going to try to hold you to that. Dr. Hilary Babcock, Professor of Medicine in the Infectious Diseases Division at the Washington University School of Medicine. Thanks for joining us today.
Thank you.
But of course, the top story we've been watching here, the layout and the plans to roll out vaccines here. A CDC panel set to vote today on rollout plans to answer who will get the vaccine first. Over that timeline that Vice President Mike Pence has laid out of about 2 weeks in getting vaccinations started, panel's expected to weigh in on who is expected to get that first. Of course, frontline healthcare workers top of mind, along with residents in nursing homes and other long-term care facilities. But let's kick off our coverage here in the second hour with a focus on just that story with our guest today. Dr. Ebony Jade Hilton is Goodstock Consulting co-founder, medical director, and associate professor of anesthesiology and critical care medicine at the University of Washington. And Dr. Hilton, appreciate you joining us to chat today. I mean, when we talk about this has been what we've all been waiting for here. And Vice President Mike Pence saying it's going to be happening in the next 2 weeks here. So what are you expecting to see with this rollout of these vaccines and how it should go in your mind?
Yeah. Well, thank you for having me. With this idea of a vaccine, it is the light at the end of the tunnel. But what we do know is that there's only a few available. Pfizer, for instance, which should be the first rollout, will have enough doses for about 20 million people. Moderna, maybe 10 million people in December. But what we know is that there's 20 million healthcare workers. There's 50 million people that are over the age of 65, 100 million Americans with pre-existing conditions. And so how do we make sure that this is done with the lens of equity, that those who are at greatest risk of not only getting infected, but also dying are actually being made available for these interventions first?
So what does that equitable distribution look like?
Right. So I think we have to look at the numbers. You guys are big into financial numbers. I'm big into disparities numbers. And what we know is that African Americans, for instance, are dying at 3 times the rate of Caucasian Americans. We know that Latino Americans are also dying at 3 times the rate of Caucasian Americans. So looking along the lines of race has to be put into this category, but also age. We know globally that those who are 65 and older make about 9% of the global population, but they account for about 30 to 40% of all COVID-19 cases, right? They make up about 80% of all those who have passed away from COVID-19. And so when we're thinking about how to distribute this first, I do think we need to consider our healthcare workers that are going to be face-to-face with these ever-climbing cases. But also we have to be very targeted on certain groups and population. Those are going to be those of racial minority groups, those are older population, and those with the pre-existing conditions. Once we have those big 3 buckets of people vaccinated, then I think we can go into the less riskier populations as we continue to do the basic simple precautions of wearing our masks, washing our hands, and avoiding any large crowds of people.
Yeah, looking beyond, I guess, the first rollout of the vaccines that we're going to be seeing here in short order, there are questions that you're talking about equitable distribution. Beyond that, there are also concerns that Americans, largely in those communities of color, which have not gotten flu vaccines in terms of the percentage that we've seen from white Americans, what can be done on that front. So when you look at this and you weigh those concerns and you weigh the concerns that the actual health staff workers here in this country might not be enough, what kind of boost are you expecting to see here from government efforts to really maybe roll this out and not just having doctors and nurses here, but also pharmacists, other medical workers coming on board here to help get this vaccine out to millions and millions of Americans?
Right. I think the main thing is we have to be intentional. The reasons why minority communities aren't necessarily getting vaccinated isn't all put on what we call the trust or mistrust of the system. I don't think it's only that. I think it's literally lack of access. With COVID-19, we saw the testing, that the lack of access of or the ability to be tested was literally disproportionately impacting communities of color, that the testing centers weren't placed within those zip codes. And so moving forward, we have to have this intentional idea of How do we make sure we bring those vaccines to those communities? When we're looking at Pfizer, for instance, with their vaccine, we know that it's going to have the obstacle of having to be really, really cooled down to negative 90, negative 70 degrees. And therefore, they're going to have to be certain systems in place to make sure that happens. If we know that to be true, and we've known that to be true now for months, where have these developments been made that are going to place those areas of this cold distribution into those communities? Have we put money and resources to make sure those rural communities, those urban communities, will have those storage units made available to them? And so I hope with the next administration, we start to be proactive in those measures to say, let's do it now, so that we're not still trying to play catch up come April, May, and June of next year.
Doctor, a big part of making sure enough people are inoculated is convincing them to get it. And on that front, there's been a lot of concern about the safety of these vaccines. You've specifically pointed to concerns around the diversity of the trial. How comfortable are you when you look at a Pfizer or a Moderna in terms of the types of trial they've conducted and the diversity in the patients they have tested?
Right. And, very early on, Moderna, for instance, made a big push to say we need more diversity along the lines of race in particular, that we need more participants to agree for these trials. And we know historically why there was a mistrust in the African-American community in particular to the medical community. They had reasons. Tuskegee was not that long ago. It literally ended in 1972, 10 years before I was born. We know the happenings of Flint, Michigan that are happening still today, where we have these distrusts of the system and doing what's best for the people. So moving forward, I think the medical system, we owe it to the people to prove to them that they can trust us. And whether that is us being more transparent and us showing us getting the vaccines ourselves, that's one of the avenues that I've actually explored to show patients and to show my community that I'm willing to do this to me so that we can keep you alive. And I hope that in sharing that vulnerability with people, that they may be able to say, okay, I trust it a little bit more too for my body if they're willing to do it too. So it's going to be those efforts of truth and transparency and truly communicating with the community and not at the community is what we have to start doing from here on out.
That's important. And Dr. Hilton, I should also note, I think I owe you an apology. I introduced you as a doctor from the University of Washington, and that was a mistake because you're from the University of Virginia. As a former Virginia boy myself, got to correct that. Maybe it's because I'm a Hokies fan. It could have been subconscious. We'll see. But Dr. Ebony Jade Hilton, Associate Professor of Anesthesiology and Critical Care Medicine at the University of Virginia. Appreciate you joining us.
Thank you so much.
For more on this, we want to bring in Dr. Craig Spencer. He's an emergency medicine physician and also the Director of Global Health and Emergency Medicine at Columbia University. And Dr. Spencer, it's great to have you on the program. Let's start with what Anjali just ended on, and that's the new guidance that we're getting from the CDC. They're now recommending quarantine between 7 and 10 days, down from the initial 14 days. Does this new guidance, does this make sense to you?
Absolutely. 14 days is the overwhelming majority of the time, the maximum time that we'd have to worry about someone potentially being contagious if they've been exposed. Decreasing that down to 7 or 10 days is going to be helpful because, yes, there may be some people, a small percentage of people who could still be contagious after 7 or 10 days. That gets the vast majority of people. And it makes it a lot easier on people who have to go to work, who otherwise need to leave the house. Now, it's important that we clarify it's 7 days if you've been exposed and you're able to get a test in the last 2 days, so from on day 6 or on 7. And it's 10 days of quarantining if you don't have any symptoms. So if you have symptoms on day 9 or on day 10, you should still continue to quarantine. You should get a test. And you should still, up until day 14, obviously take the same measures, limit your interactions, because you could still potentially be infectious.
Dr. Spencer, help us understand a couple things. When Anjali talked about the potential for 100 million doses by March, that's 50 million. If it was 200 million doses, so if it's 2 doses that each individual needs, that's 100 million people that will be inoculated. Frontline workers, senior citizens, nursing homes. We saw the CDC proposal. Those people who are inoculated against the virus, they can still transmit it, though, or can they not once you have the vaccine in you?
That's a great question because honestly, we just don't know. One thing we haven't seen much more than just a press release on both the Pfizer, BioNTech, and the Moderna vaccine. We know that they're highly efficacious, but we haven't seen the actual studies. So we don't know, and we may not get that information. We're going to have to assume that even if you're protected, which is great, and it seems like both these vaccines provide good protection, especially from getting severe illness, we don't know if it's going to mean that you can't get the virus in your body and potentially still pass it on to others, even if you've been vaccinated. That's why it will be important that people, even when they're vaccinated, continue to take a lot of the exact same steps we're taking now: washing your hands, wearing a mask, socially distance, until the vast majority of the population is able to be vaccinated, because the virus could still potentially spread.
And the second part of this question comes from all of the investors who are talking about pent-up demand, money on the side, that with a vaccine will come pouring back in. If you have been inoculated against the vaccine, but you can still transmit it, we don't know about that yet. We could still have lockdown situations. We could still be wearing masks and restricted numbers of people in stores and in restaurants, because even though you yourself are protected, you could infect somebody else. This is a real problem even after the vaccine, is it not?
Absolutely. The one thing that people need to recognize is that just because we have vaccines, the pandemic is not over. The majority of the people listening to this program right now may not get a vaccine until April, May, maybe even later. It's going to be prioritized for healthcare workers, people in long-term care facilities and in nursing homes. There are going to be people who, for other underlying health reasons, may not be able to get a vaccine. People who are pregnant, for example, or are immunocompromised. And they're going to require all of us to continue to do the exact same thing we're doing now, which is wearing a mask, socially distancing, because the virus will still be spreading in our communities until, again, the overwhelming majority of people have been vaccinated, and that's still going to be a long way off.
Dr. Spencer, when we talk about getting the vaccine here in the US, when we still look at the surveys and the results of them, it shows that a decent number of Americans are still hesitant to get a vaccine when it's ready. There's been the notion thrown out that maybe we should think about paying people who are willing to get vaccinated. Not to get political with you, but just from what you've heard from your patients and the conversations that you're having with your colleagues, is this something that would potentially make sense?
You mean paying people to actually use this? I think this is difficult. I think what we need to be doing and what we should have been doing really over the past few months is we should have had a coordinated effort on behalf, led by our CDC, by the FDA, by our other long trusted public health organizations, to reach out to these communities and let them know that, yeah, we're doing this in record time, but that doesn't mean that we're cutting corners. We need to really be thinking about specific communities that have been disproportionately impacted in this pandemic and have reported that they're less likely to maybe trust or receive a vaccine. I'm thinking of communities of color, Black and brown communities across the US. We need to reach out to them. We need to have been reaching out to them for some time. We've developed vaccines in record time, but we haven't been doing that good, important community kind of trust building activity that needs to set the stage really for people to feel comfortable and to trust that this vaccine is safe, effective, of high quality, and is something that they should receive.
Dr. Craig Spencer, great to have you on the show. We hope to have you back again soon. Emergency medicine physician, also director of global health and emergency medicine at Columbia University. Thanks so much for taking the time.
Thank you.
I want to start the show, however, on the coronavirus pandemic. There's now more than 13.9 million cases of coronavirus in the country. So we're definitely going to be hitting more than 14 million positive cases in just a day or so. And the death toll has now risen to roughly 274,000 people. This is all according to the tracker at Johns Hopkins University. Now, this is a huge leap in the number of case totals. If you guys remember, just yesterday, we were hovering around 13.7 million, a little bit under 13.7 million. So this means that for the first time, the United States has hit a case count of 200,000 positive cases of the virus. That is in just one day. Hospitalizations are also soaring. 100,000 people were hospitalized with the virus just yesterday. So this is some very tragic and very sobering records that we have been hitting when it comes to this pandemic. I want to dive more into this. Now we're joined by Suzanne Judd, an epidemiologist at the University of Alabama at Birmingham School of Public Health. Dr. Judd, thank you so much for joining us today. I want to start, given those statistics, with what CDC Director Robert Redfield said. The next 3 months are going to be, and I'm quoting him here, the most difficult in public health. I'm wondering for you, you're an epidemiologist, you work in public health, this is your area of expertise. What does that mean exactly? And why will the next 3 months be so difficult and so deadly?
So we're used to this in public health. It's always a dark time in terms of infectious diseases. People are getting together for the holidays, they're indoors. They are coming in contact with lots of different folks. Kids are getting out of school and going to see grandparents. So this is a normal time that you would see a rise in things like stomach bugs, the cold, flu. But this disease is so different, and we know that. So it's very scary that we already see such high circulating numbers in November. And we know we're going into a time when it's going to be even higher. So that's one of the reasons you keep hearing public health people raise the alarm and say, this is serious, this is going to get worse. Our hospitals are already full. This is going to force our healthcare workers to have to make really difficult decisions about who gets hospitalized, who goes to a different type of care. And it's just going to be very difficult for the public health and hospital systems.
Now, another update from the CDC is also that they're forecasting, I want to get the numbers right here, up to nearly 20,000 deaths the week of Christmas from coronavirus, roughly 9,500 up to 20,000 for that week. I'm wondering if when you hear numbers like that, do you view that as a peak, or do you think it could actually even get worse beyond that?
My guess is it could get worse beyond that. Again, people are going to start getting together that week, those last few weeks of December. They're going to get together for the new year, and they're going to think they're safe. And so cases, we'd expect them to rise in January beyond where they are right now, which means that deaths will rise beyond where they are in December. Actually, I think the peak deaths will occur closer to February or March.
You know, a lot of folks have been doing quarantining. They've been doing tests to get out of quarantine here in New York. In order to leave a quarantine, you have to test negative 4 days after you arrive into the state after previously showing a negative test. And, you know, myself and a lot of the producers were chatting about it a little bit earlier, and it seemed as if perhaps some of these, testing day numbers are a little bit arbitrary, or that there's a lot of wiggle room really for people to kind of slip through these cracks and still actually be positive, even though they've tested on certain days and therefore are appearing negative. Do you see these kind of testing days as arbitrary? Is there a science behind it? Or are you seeing as well that there's a lot of problems with the way we've been approaching testing and receiving negative test results, people thinking they're negative when in reality they're not?
Yeah, you and your producers are spot on. It's not that it's arbitrary. There is data behind it, but you remember from high school math, if you're looking at an average, which is what we use, that means there are a lot of people that are either above or below the average. It may take them longer to become symptomatic, or they may not develop symptoms at all. So we go with what works for the bulk of the population, and generally in public health, that keeps people safe. That's why we don't need everyone to get vaccinated, because if the bulk of people get vaccinated, then everybody else stays safe. But like you said, that does mean it's possible for a few people to fall through the cracks. But again, our hope is if we can keep 80% of the population safe, we can manage cases in the other 20%.
Well, it seems as if they're surging all around the country. So I'm not entirely sure how well we are doing on that front. To that point, Los Angeles Mayor Garcetti said that the city was nearing its tipping point, ordering people to stay home. I'm wondering, from your perspective, how hard is it to fight the spread when big urban centers like Los Angeles are on a knife's edge? And really, tipping into what, really? When we say a tipping point, he said tipping point. I'm wondering, when you hear that, what does that mean? What does it mean when you tip over? If this is where we are now, 200,000 cases, 100,000 hospitalizations, almost up to 20,000 deaths we're looking at for the week of Christmas. Well, then what's on the other side of that if this is before we've tipped over?
It's what we saw in Italy back in the spring, back in February and March. It's people going to the hospital and being unable to be admitted. That's the tipping point. And a lot of Americans have a hard time imagining that because they think of themselves getting sick and being at home, and they can't even picture what it would be like to go to a hospital and have that hospital say, "I'm sorry, we're full and you're not sick enough to be admitted." That's what the tipping point looks like. It looks like hospitals that cannot admit people that need to be admitted.
So, Dr. Judd, you're kind of hitting or hinting at this like doomsday scenario. I feel like we were talking about a lot back in March, back in April, back in May, where folks were saying, you know, doctors are now going to have to decide who, quote unquote, lives and dies. You know, the hospitals are going to have to, and you're kind of mentioning this, right? You know, that people are going to the hospital and they might be told, listen, you're not sick enough and we just don't have any room for you. Do you think that some of those headlines, you know, that we had been seeing, those fearful headlines back in March might actually become realities in December, realities in January?
It's very possible. That's why cities like Los Angeles are saying they're on the knife's edge, because they are getting very close to that point that if they see a surge in cases, they can't manage all of those cases with the hospitals. And it's not just the hospitals, it's doctors and nurses and the people that clean the hospitals. There's so many people that are needed to keep a hospital running. And if it's full at capacity, they're not able to do everything they need to do. So yes, it's definitely, I don't know about doomsday. I think that's a bit much, but it certainly gets into that situation where people have to make uncomfortable decisions that we don't like.
I'm wondering, you know, given that you work in public health and that kind of involves the public participating, obviously, with doctors, with epidemiologists like yourself to really all be in this together to fight something like a pandemic. I'm wondering what you make of this disconnect that we seem to be having, where on the one hand, we keep repeatedly saying, I keep repeatedly saying how many case counts we have, how many death counts we have. And yet, on the other hand, it seems as if you were to walk out on the street, you might not even know sometimes that a really deadly pandemic is going on. What do you make of that disconnect? And how do public health officials and public health researchers and folks that are working in this field navigate that?
It's really challenging when you've got an invisible threat like a virus and say 1 in 100 people have it and are actively fighting it. The likelihood that you actually know somebody that has it and is fighting it is low. So people have, for the last 9 months, been going around living their lives. They say, oh, if this hasn't impacted me, I must be fine. I'm going to go back to my normal life. So we've been trying to actively combat that with messaging, messaging that's more simple, I would say. CDC has done a really good job at revising some of their guidelines so they make sense to people and trying to be a partner with the public. But you're right. Right now, it's really challenging to communicate to the public in general, especially because this disease has become politicized, which is very normal for public health diseases. HIV was highly politicized in the 80s. But it's a huge challenge, and we have to rely on our psychology colleagues and our health behavior colleagues to help us develop messages that explain what's going on and why, even though you may not know somebody that has gotten COVID and been very sick, it doesn't mean that you still yourself couldn't get sick or someone else couldn't get sick. Those are the messages we have to continue to repeat to people over and over again and let them know, wear a mask, stay 6 feet apart. Don't go places where you're eating because your mask is going to come off. So try not to eat in public in large gatherings. Those are the kind of messages we have to continue to repeat over and over again.
You know, I only have about a minute left here with you, but this has been a pretty, I think, sobering conversation. So I'm going to try to inject a little bit of optimism here to at least end on, Dr. Judd. So we obviously have this vaccine coming out, and you know, there is that, you know, pretty glib phrase, however, it's always darkest before the dawn. I'm wondering if you do see the light at the end of this tunnel, if you do think that this might be the last final painful push through before, you know, sunny skies up ahead, we have the vaccine and we can really put this behind us.
Without a doubt. I think that we can see the light at the end of the tunnel. It's unfortunate it's falling right in the middle of our holiday season, because people would love to have the light right now when it's really turning into our darkest hour. But again, the light is there. There are several vaccines that look good. And by summer, we should really have control of this virus, providing it doesn't mutate or do anything that is beyond what we expect. But we certainly can see the light. It's just that right now we're going through the darkest part of the tunnel. So we can't focus on the light. We've got to focus on getting through this next 3 months.
All right, focus indeed, but a little bit of a nice bit of optimism to end on there.
Definitely.
Dr. Suzanne Judd, epidemiologist at the University of Alabama at Birmingham School of Public Health. Thank you so much for joining us.
Thank you for having me.
We're still watching the latest headlines coming through here day after day on the coronavirus front. Announced COVID fatalities topped 2,700 yesterday, by far the deadliest day yet in the country from the disease. And that comes as hospitalizations continue to set records across the country. So let's start there for what we should be expecting in the months to come as we approach the holiday season. Joining us now is Dr. Hiro Tipernini, emergency medicine physician in Arizona and former candidate for Congress in Arizona's 6th district as well. Dr. Tipernini, it's good to be chatting with you again today. I mean, the numbers are pretty dire here when we talk about hospital staffs being stretched, regardless of whatever community you want to focus in on here. What are your expectations in terms of battling this now and where we're at in this pandemic in the month of December?
Yeah, well, good to be with you, Zach. I certainly wish we were talking about a more positive topic. But that being said, yes, we are in, these are dire numbers that we are seeing. As you mentioned, the national death number was a record. We've also seen a record number of deaths here in Arizona as of this morning. The most recent number, we're almost up to 7,000. We had 82 just reported. And look, we have a vaccine coming, and so hope is on its way. But until then, it's really important that we all do what we can to continue to mitigate the spread, because the numbers are going up. There's no end in sight. And even once the vaccine is out, we have to remember it will take several months before it makes its way through even first administration throughout our population. And obviously, there's still a lot to learn about the immunity it confers and how it allows us to start moving back through our communities safely. So until then, it's so important that we continue to practice these mitigation efforts. Just yesterday here in Arizona, there were clinical leaders of all of our major hospital systems that wrote a letter to our governor asking to implement some new measures to be very clear about the situation we're in and that we are approaching hospital capacity. We will have to implement care crisis standards. And these are all worrisome times. And it's important that we all continue to be very vigilant.
And on that front, we've seen a number of state leaders adjust some of their decision making when you compare it to where things were back in the spring. Governor Cuomo here in New York, for example, saying it's not about the positivity rate anymore. It's about the capacity in the hospitals, and that should be guiding the restrictions moving forward. What are you seeing on the ground there? It feels like we're having these uncomfortable conversations again about who actually should be getting surgery, who should be getting care. Can you give us a little more insight on the conversations that are happening in Arizona?
Yeah, absolutely. I mean, look, you're right. Having capacity is one thing, but our goal really should be not to, consume all that capacity. It should be to keep people out of the hospital, to keep them well. Just because we have beds doesn't mean that we want folks to take up the ICU. We certainly don't always have staffing. Right now, Arizona's Department of Health has requested an additional 500 nurses to come to Arizona to help us with the care. So just having a bed does not mean that we have the capacity. And more importantly, it's really a critical issue that you bring up. We are putting elective procedures potentially on hold. It also, having these numbers in the hospital and in the emergency departments, a lot of times it deters other folks who are truly having other kinds of emergencies from seeking the medical care that they need. Sometimes they're staying home far too long with the illnesses that they have because they are ambivalent about going to the hospital with coronavirus being so prevalent. So there are widespread implications of these numbers rising and rising. We don't want to implement the crisis standards of care, which is what I was referring to earlier, that the clinical leaders of all major hospital systems here in Arizona have told our governor that if we do not see a quick and urgent and decisive action, set of actions put into place, then we will have to implement those crises of care, which means we are talking about, potentially making choices, right, of who gets that ICU bed, who gets the ventilator, who gets the extreme interventions to prolong their life. That's something that no medical professional ever wants to have to make those kinds of choices. And we never want to see our hospitals go to that place. So it's imperative that we continue to be very vigilant and keep folks out of the hospital, keep them well. And these guidelines that have been proposed are very reasonable. We're talking about limiting gatherings to less than 25 people, making sure that we have no group athletic events. They're asking for a curfew as well at nighttime at 10 p.m., making sure there's no indoor dining, as well as things like wearing a mask in public, trying to stay home as much as possible, washing your hands, staying home if you're sick, and so forth. We have to do everything we can to mitigate the spread. We are at a very critical point right now all across this nation.
Yeah, and Doctor, when we look ahead to the vaccine rollout, just looking across the pond, the UK, obviously the first country here to approve Pfizer's vaccine to start getting that rolled out. When we've heard from Boris Johnson, he's labeling it as challenging to get it out to the public. And I think here in the US, it'll be much of a similar story. But when you look at kind of demand right now on healthcare staff, I guess silver lining, you'd expect it to improve once we get past Christmas. Moving forward, the IHME models shows that deaths are expected to peak in January here. What are your expectations on maybe the stresses of getting the vaccine out and how it's going to need to be an effort beyond just hospital workers here, but also, I guess, local pharmacists potentially also being called in here? What do you see playing out as we try and get this vaccine out to the public?
Yeah, this is really one of the most massive coordinated efforts that our country will ever undertake. Whether it's about the manufacturing of the vaccine, of the supplies, of the syringes, the needles, distribution, but then also, as you're referencing, administration of these vaccines, and that takes. That takes personnel, that takes real coordination of, understanding which populations are greatest at risk. We have to, yes, vaccinate our first responders, our essential workers, healthcare workers, but the administration of this and doing it in a very timely manner, this is a huge undertaking. It's going to require sort of all hands on deck approach. We need a strong supply chain. We need to make sure that we have a very comprehensive strategy that is fully outlined. And that's why it's so important that we are as, clear on these instructions and this sort of roadmap as we can be, because this is going to require all additional personnel. It's going to be very critical that we get folks vaccinated in a very efficient manner. And also keeping track of folks and making sure that we know who's been vaccinated, who is due for, ultimately a second dose, and also monitoring the effects of this, because we have to remember this is a very new vaccine. This is still a novel virus we are still learning a lot about.
And doctor, I want to get back to a comment you made earlier about the state calling for 500 additional nurses. Where are you going to get those nurses from? Are these within state? We heard some of these stories early on in the pandemic, but at that time, the infections were largely limited to specific states. Now we're seeing an increase across the country. How confident are you that you have the staffing in place to be able to meet the demand?
Yeah, that's a great question, because we're not the only state, right, out there making requests for additional staff. And so, yes, there is sort of some level of competing with the needs of other states, which is all incredibly important as well. So this is not an easy ask. It is something that our Department of Health Services and our director of that department has asked for. And those are expected to be nurses that are not in Arizona already. So it is a question question of whether that staffing request can be fulfilled, how efficiently it can be fulfilled. And remember, this isn't just nurses in general. There are different areas of care, right? There's critical care nurses. There might be nurses that we need more for other areas of the hospital because of the shortage and because of the, sort of revamping and directing a lot of our current nurses, say emergency department nurses and so forth, to work more on these critical patients. So this is a challenge, absolutely, as you note. And we are, in the most crude terms, I guess, in competition with other states. Everybody across this nation is looking for additional staffing and resources. This will not be an easy, request to fill. And we will see how it pans out over the next several weeks.
And hopefully it does improve, but we shall see. We'll be watching it closely. Dr. Hero Tipernini, appreciate you taking the time to chat today.
Thanks so much for having me, Zach. Take care.
Welcome back to Yahoo Finance Live. Well, on Thursday, we saw 216,000 new cases of the coronavirus reported in the U.S. 22,857, roughly 2,900 Americans dying as a result. And we've seen a number of governors move to impose new restrictions. Over in California, Governor Gavin Newsom laying out guidelines that are based on hospitalization rates. We've also seen that play out in New York. Over in Connecticut, Governor Lamont facing new pressure to close gyms and indoor dining as they see case counts rise there as well. Let's bring in Dr. Luke Davis, who's an associate professor at Yale School of Public Health and an attending physician at Yale Medicine and Yale New Haven Hospital. Dr. Davis, it's good to talk to you today. I want to start by talking about this hospitalization issue, or just more focus on that. We heard from Governor Newsom here in California talk about how the restrictions will be based on the capacity that individual hospitals have. That's a little different than what we saw early on in the pandemic, where there was much more focus on the positivity rate. How much more effective do you think this can be, especially at a time when there is so much fatigue about restrictions?
Well, Kiko, thank you for having me on. And there are a lot of indicators, of course, that our governors are looking at and trying to understand. But I think the bottom line, we as physicians see the patients coming into the ICU, and we know that we only have so many beds, but even more importantly than that, we only have so many critical care nurses, respiratory therapists, and critical care physicians. And the message that I would just want to send is that to get the best outcomes, we need to have enough time and enough capacity for those individuals to do their jobs. And as these numbers increase, it's taken us back to some of the dark days that we saw last spring.
Doctor, we've seen states battling in different ways. Akiko's kind of laying out the hospitalization percentage threshold used by some. It's different each state you go to here. And all of them, when you talk to governors or politicians, seem to be pointing to COVID fatigue here. How much of kind of the state-by-state rules making might be doing more harm when you kind of have to figure out what's right? You even saw the CDC kind of shrinking their quarantine guidelines here because kind of highlighting the fact that Americans might not actually follow the rules if you kept it so long. So talk to me about where we're at in terms of fatigue right now and how hard that's making it on medical staff to make sure Americans comply with guidelines.
Well, nobody likes to talk about serious things like being hospitalized or getting into the ICU, much less dying of COVID. So I think it's certainly natural and understandable that people are reluctant to face these items. But I think that's really why we wanted to speak out, is to say, this is what we're seeing here on the front lines. And just to make people aware, we do have a choice. We know increasingly about COVID and what we can do to prevent it. And that's really the fundamental message that we want to get across is avoid large gatherings, wear masks. This is really a critical time. I think one thing that's been misunderstood is that those things that we talk about limiting exposure help, but when the case rates get so high in the community, that is only reducing things from a very high level to a moderately high level. And the best thing that people can do is stay home.
And to that point that Zach just made about COVID fatigue kicking in, we had the Restaurant Association in LA, for example, sue public health officials and say, please, you have to present the science for why outdoor dining needs to be banned right now. I know in the state of Connecticut where you are, there is a push now to ban indoor dining as well. What does the science suggest on how much the virus's spread can be curbed as a result of eliminating any kind of dining except for just takeout.
Right. I think the approach that's been taken has been a phased approach here in Connecticut and other states around the country. And, of course, we can monitor the number of cases and number of hospitalizations. But really, at this point, we're approaching a critical point. Once our ICUs are full, we know from the data that's come out in the spring that the mortality in those dark days of March and early April, mortality was 3 times what it was as time went on into June. And that's not so much because we have new therapies for COVID. We have some modest therapies that are beneficial, but it's really because of having enough providers to be able to have enough time to attend to these patients. And I think that's really the message that we want to get across, is that the other indicators, they are lagging indicators compared to what we're seeing here in the ICU.
Yeah, that's really what's scary when you think about how these are lagging indicators and you see cases continue to set daily records, what that's going to mean when you get further along down the road. I do want to ask you about one of the issues that President-elect Joe Biden is saying that he's going to try and institute when he comes into office, 100 days of wearing masks. At a federal level, it might seem small, but I'd be curious to get your reaction to that. If you do have a national mask mandate, how important that would be just to kind of put it top of mind for Americans everywhere rather than having to deal with governors who might not even want to put that into place.
Right. Well, I mean, I think having spokespeople to get out there and encourage people, I think, can be as important as mandates. I do worry that some people might take the wrong idea from a mandate. But we know that masks have an enormous benefit, both in terms of decreasing transmission to others and protecting the wearers. And we just really need, at this point, I think, to do everything that we can. In regard to your earlier question, I think that the message that we have is that if we can get this crisis under control and move towards a vaccine, it's better to do that. It takes only a week or two to fill up our ICUs, but then it may take 1 or 2 months to empty them out. And I think that has a much worse impact on our society in terms of deaths and also on the economy overall. The message to people is that we're almost there. Just hold on a little bit longer.
All right, Dr. Luke Davis, Associate Professor at the Yale School of Public Health. Appreciate you taking the time to chat. I know you're busy. Be well, my friend.
Thank you, Zach. Thank you, Kiko. Nice to talk with you.
Well, for more on this and what this exactly means for the healthcare industry and for mitigating the spread of COVID-19, we want to get the healthcare perspective of all this. And for that, we want to bring in Dr. Rashid Desai. He's the Chief Medical Officer at Osmosis and also the former Epidemic Intelligence Officer for the CDC. And Dr. Desai, great to have you on the program today. We just heard Doug Parker talking to us just about those logistical challenges when it comes to distributing of a vaccine and the role that airlines are playing in it. From a healthcare perspective, though, how are you looking at some of these supply chain obstacles that we have in front of us?
Well, the first thing for folks to know is that when they think of a COVID vaccine, that it's not just a single vaccine. It may be 2 vaccines, depending on which one you're talking about, especially the ones that are coming down the pipe first. So that means that we have to think about how to get people vaccinated and then bring them back to get a second dose. The other thing is how to keep this vaccine in what is often called cold chain. And all that really means is fancy talk, but it essentially just means keeping it cool so that it doesn't go off, similar to keeping food cool. So you need freezers, fridges, things like that to kind of maintain the viability of the vaccine. And what happens if you don't have the right temperature, if a clinic doesn't stock a freezer that goes that low? So things like that are just very basic, but this is what's going to make or break whether this vaccine is able to get distributed.
Dr. Desai, if it winds up being the Pfizer vaccine that most people need to have in storage, how realistic is it to expect a hospital or a medical center to have a refrigerator that can go down to -100? Is there going to need to be some kind of government funding to help put those kinds of units into place?
Yes, absolutely. A lot of hospitals may have one, but many hospitals will not, especially if you're talking about a smaller hospital that simply doesn't need a freezer like that or doesn't have the space for it. So you're definitely going to need some mechanism, whether that's state funding or federal funding, to help hospitals apply for and get that freezer on site quickly. And now there might be hospitals out there that say, look, money is not the issue. where do we even get this freezer? And so how do you even procure that freezer and get it, to your facility right away? So all these things are going to have to be worked out very, very quickly. And we saw what happened with logistics around PPE. And that's something that, you can basically jam a bunch of them into a cardboard box and mail it off. And even that was really hard for this country. And so it's going to be really, really intriguing to see how we deal with this freezer issue, which is much more nuanced and has much more peculiarities to it than simply PPE.
Dr. Desai, we got some updated guidelines from the CDC today. And for the first time, the agency is now advocating for universal mask use indoors. When you take a look at the fact that they're doing this now in December, nearly 10 months or over 10 months into the pandemic here in the US, is this something that should have been, or is this an announcement, I should say, that should have been made months ago?
Yeah, absolutely. I think two things should have happened months ago. One, you can make these announcements like, hey, wear a mask all the time or wear it indoors or whatever you might say. But the other is actually getting people to do it. You have to win the hearts and minds of people. So it's not sufficient just to put out a pronouncement. They've got to actually put out a campaign for public health education to get people to get bought into the fact that we need this. Right now, we have so much COVID disease that it's imperiling our hospitals' ability to manage themselves and not kind of get at the brink of having to require parking lots and things like that. So right now is why they're, advocating for this. But yeah, certainly this should happen before we got to this point.
Does this mean that if you're going to wear a mask indoors, I guess restaurants, even if they're open at 25% capacity, that day is done for at least, another 90 days? How do you eat with a mask on?
Yeah, it's a good question. It's a basic question. So what you do is you'd say essentially then you shouldn't be having dining indoors. You should go home and eat your food, essentially just take out. So that's the kind of thing we have to work through. You shouldn't have people wearing a mask and then taking it off for the majority of their time within a restaurant. What are they doing in that restaurant anyway? So this is the sort of thing we have to work through and actually, again, get restaurants bought in on this. And they're going to say, we're going to lose a lot of business. We may go out of business. And that's why you need the government to step in and help these restaurants offset their losses on dining in so they can get by on just the takeout and that government stimulus.
Dr. Desai, always great to have you on the show. Thanks so much for taking the time to join us today.
Absolutely.
I want to turn now to Dr. Sejal Hathi. She's a physician and clinical fellow at Massachusetts General Hospital and host of the podcast Civic RX. Doctor, thanks so much for joining us. It's always great to have you here with us, although I wish we were speaking about a better topic. But we're hearing that hospitalizations are on the rise. I'm wondering if you can paint really the picture for us for what you, your friends, their colleagues are seeing on the ground in Boston and other hospitals around the country.
Yeah, well, thank you so much for having me here. What you're learning about, reading about on the news is absolutely what's transpiring within the hospital walls all across the country. And the reality is, it's difficult when we are cloistered within our homes to truly envision the horrendous tragedy that has struck every hospital, every state across the country. But healthcare workers are suffering. We're seeing more and more individuals with COVID-19 hospitalized, or ICUs are filling up. Meanwhile, there are still thousands of Americans who refuse to acknowledge the reality of this virus, let alone abide by the behavioral precautions prescribed by public health officials. And we're tired, we're frustrated, we are depressed. Rates of mental health issues among my colleagues are skyrocketing. It's really a grim time for all of us. And yet we know, right? We know that each of us still has the power to rewrite this history. The University of Washington published a study just a few weeks ago stating that if 95% of the American public, and hopefully we'll see this when Joe Biden enters office on January 20th, based on his press conference yesterday, if 95% of the American public were to simply don masks, we would save 130,000 lives over the course of the next few months. That is tremendous. So we know what works. We just need to make sure that we practice those precautions.
I'm wondering if you think that we're going to be seeing a scenario where hospitals have to turn patients away if they're not already. And based on how we're doing right now, which is not well, if you think that that scenario is coming soon.
Yeah, so, what's interesting, Dr. Ashish Jha, who's dean of the Brown University School of Public Health, tweeted just a couple days ago that he's worried that fewer and fewer people who would have been admitted just a couple months ago are now being admitted with COVID-19 because hospitals are simply erecting stricter criteria for who can come within their walls and get the treatments and the care that they need. And we see in California as well, Governor Gavin Newsom just announced that the strictest stay-at-home orders since the start of this pandemic, stating that ICUs are threatening across the state to reach 85% capacity. If they do that, businesses will close. And look at what's happening. Case study of the damage that can be done when the government doesn't act quick enough. Hospitals there are filling up. They've reached a 50% positivity rate across the state because they simply can't cope with the number of people who are coming in. So to answer your question, I am worried that unless we do what's right, and right now there's no indication that we will, based on the history of this pandemic, hospitals will fill up. There won't be enough ICU beds for those who need it, and more lives will be lost.
I want to ask you, Doctor, how quickly do you think a vaccine will be able to stop this pandemic in its tracks? We already hear that a vaccine is being rolled out in the UK. Pfizer and Moderna say that once they get their authorizations here in the United States, of course, they can start rolling it out as early as this month, so before the new year. Are you anticipating that, this time next year, the pandemic will kind of be a fading, terrible moment in all of our collective history?
Well, I do hope and do believe, I'm hopeful that by this time next year, we will all be in a much more sane place, but life is not returning to normal, I think, for several years. And there are still multiple questions that remain about the vaccine. So to answer your question first directly, we know based on the independent panel that reported to the CDC earlier this week that in December, should things go well on December 10th, when they're reviewing the applications for the vaccine, in December, healthcare workers, nursing home residents are likely to get the first dose of the vaccine. Of course, 3 to 4 weeks must transpire before they can get their second dose, so they're unlikely to achieve immunity before January. But at least we can distribute the vaccine to 20 million people over the course, perhaps, in the United States of the next couple of months. In February and March is when we'll start to see the next priority groups of people over the age of 65, especially those over the age of 75, those with chronic diseases that would put them at especially high risk if they are infected, as well as essential workers, so grocery store workers, those in education, those in food distribution. They will get the vaccine around that time. But again, it's going to take a couple months for them to achieve immunity. And then finally, in April, May, and June is when the rest of us, the broader public, is likely to gain access to the vaccines. But we still don't know, for instance, how long the immunity granted by the vaccine will last. We don't know if it's a few months, a year, longer than that. We don't know whether the vaccine can entirely stop transmission or merely prevent the most severe manifestations of COVID-19. We don't know if there are rare side effects or particularly deleterious side effects of the vaccine that simply in these few months that we've been testing it, which is just a fraction of the time we test typical vaccines, we don't know if those will emerge in the coming months, hazarding the safety of taking it. And we don't know, too, whether Americans are going to trust the vaccine, trust its efficacy, trust its safety enough to get it in record numbers. I personally am not going to feel safe returning to my sense of normalcy until 70% of the American population is vaccinated, and until some of these questions are further resolved. So I think the news of these last couple of weeks is very promising, but we still have a long way to go. And that's why it's critical that people practice these social interventions, physical distancing, mask wearing, hand washing, minimizing non-essential travel over these coming weeks and months.
All right, a long way away indeed. Dr. Sejal Hathi, physician and clinical fellow at Mass Gen and host of the podcast Civic RX. Always great to have you here with us to bring us, really some of those updates and some of those really realities. Thanks so much for joining us. Let's continue this conversation now with Dr. Anand Swaminathan, an emergency medicine physician in New Jersey. Doctor, thank you for joining us again for this conversation. As I just mentioned, you work in emergency medicine. I'm wondering what you're seeing at the hospitals in New Jersey. How are other hospitals that you're hearing about, in New England or in the Northeast coping, that your friends and other colleagues are working at? Are folks running out of space? Are hospitals running out of equipment? What's going on the ground?
We're seeing all of that happening right now. Yes, I think that January is going to be where we really see the peak with these two holidays or a couple of holidays back to back. But we're already seeing a surge from Thanksgiving that's coming, not just in my hospital, obviously across the state, across the region. And talking to colleagues in other parts of the country, they're seeing it as well. They're seeing huge spikes in the number of patients that are coming into the hospital that need to get admitted. And they're seeing huge spikes in critical care and patients going to the ICU, which means in the next 2 or 3 weeks, we're going to start seeing deaths rise again, because we know there's a little bit of a lag to that. We are seeing running out of equipment. So, the same equipment that we were talking about running out of in April and May, ventilators, medications, we are short of space. And we keep stressing over and over again, it's not enough to give more space or more vents. We need more staff. And that's something that we're not going to be able to fix anytime soon. You can always ramp up production of certain equipment. It's very difficult to expedite training of staff. And so it doesn't matter how much space we have. We don't have the staff to take care of the patients we're seeing. The hospital system is going to be overwhelmed very soon. And in some areas is already reaching that point.
So, doctor, what aren't we doing that we need to be doing? What does the public need to do, right, to help frontline workers like yourself really get the case numbers absolutely reduced here? Because we keep seeing these record highs coming in day after day.
It's the same thing that we've been saying for 8 months. It's good, simple public health measures: hand washing, masking, physical distancing, and not gathering indoors. And I think that last one has become more and more of a problem. I'm sure that it was a big problem around Thanksgiving. I think it is continuing to be a problem, especially as the temperatures are dropping in the Northeast. People are being forced indoors, and they're not giving up those social interactions that we were able to do outside. Now, it's easy to blame individuals for gathering indoors. That's really not the issue. We need good messaging. We need good messaging across the board, telling people this is what we need to do. And we haven't had that. We've had such a huge amount of mixed messaging. And even when the messaging has been correct, it's been really delayed in getting to people. So the health professionals have been saying the same thing. That's who the public needs to listen to. Don't gather indoors. Keep your masks on. Socially distance. Hand washing. That's what we need to do. And that also means we need to start closing some non-essential businesses. There shouldn't be indoor dining going on in any place that's surging. And if you look at the map, that means basically everywhere that's not Hawaii, we need to be stopping indoor dining, because that's a huge place for spread. So we actually have the news, at least here in New York, that Governor Cuomo will be shutting down that indoor dining. I was going to ask you if that's a measure that we need to be taking. Obviously, you just said absolutely. Yes, we need to. I'm wondering if you think that perhaps, and we were showing on the screen just for everyone at home a couple of moments ago, essentially where we have mask mandates, states and cities that are currently in lockdown. In addition, or as a part of some of these public health initiatives, do you think that we need to be more restrictive than we are right now? Because I keep hearing everyone weighing in on this, trade-off that we have to have, the trade-off of, keeping companies open, keeping restaurants open, with, the fact that the economy needs to also stay open. So I'm wondering if you can weigh in on that argument, if we need to be more restrictive, if more politicians like Governor Cuomo should be warning
listen, hey, if these numbers don't come down, we're going to have to take some of these measures?
We do need more restrictions. And the best way for us to support our economy is to defeat the pandemic. We know this. We have to defeat the pandemic in order for our economy to bounce back. Vaccines have been touted for the last couple of weeks, and vaccines are going to be a huge part of this if everybody gets vaccinated. But that's going to take a lot of time. Even if the vaccines came out today, it's 2 doses a month apart, and then another 7 to 10 days before you really get the efficacy of that vaccine. We're not going to see that for a while. So we need to be doing good public health measures, which means we do need to be closing other parts of our businesses in order to protect people. And again, we have to prioritize. Priority number 1 should be keeping everyone healthy. I think in terms of keeping things open, priority number 2 should be getting schools open and keeping them open. And in order for us to do that, in order for us to keep schools open, we have to be restrictive in other areas. That means the social gatherings. I mean, we saw over the weekend, there was a big party in New York City in a club. That kind of behavior is unacceptable. We can't be doing that because that is where this virus is going to spread. We're going to be sending people out that are going to be seeing other people who are even more at risk of getting very sick. And then we're going to have peak after peak after peak. So if we want our economy to recover, we have to fight the pandemic properly. And that means good public health measures.
And I want to correct myself. I said earlier that New York City definitely would be closing indoor dining. Actually, it's just a warning that we have right now from the officials in the state that if hospitalizations don't stabilize, they will be closing indoor dining. Doctor, I want to ask you about President-elect Biden and his healthcare team. That has been announced. It's including his nominee for the Health and Human Services, and that's going to be California's Attorney General Javier Becerra. Wondering what your thoughts are on his team. He's also included someone that we've all seen before, Dr. Vivek Murthy, for not Attorney General, for Surgeon General. I'm wondering what your expectations are given these selections in the fight against coronavirus.
I'm excited about this team. I'm excited about the COVID pandemic team as well that Biden and Harris have put together. These are critical places that we need to be active. So Mr. Becerra being in charge of HHS is huge because they oversee CDC, they oversee FDA, which means they're going to be overseeing the distribution of the vaccine, which is going to be the biggest public health challenge that we are going to see in the next year. How do we get this vaccine to everybody? How do we message this so that everybody gets vaccinated? And how do we get it so that everybody gets the first and the second vaccine, since both are going to be necessary to get that real herd immunity that we need to see? Herd immunity is not going to work with 2 or 3 million people being vaccinated. It's not going to help with only 30 or 40% of people are vaccinated. We need a large number of people to be getting it. This is a huge task for HHS. I think Mr. Becerra is up to it. I also love the CDC appointment of Dr. Walensky, who is extremely well respected by her colleagues. She is a public health champion. She has great research behind her, and the collective sigh of relief that I have heard from physicians, from nurses, seeing these people put into the proper positions has been huge. We need to restore the faith of both the population as well as physicians in the CDC, in HHS, because that has taken a huge hit over the last 8 months. If we don't have that, if we don't have faith in those organizations, we cannot overcome this pandemic. And I think that these nominees are really wonderful for us to be pushing science forward and getting everybody on the same page together.
All right, Dr. Anand Swaminathan, emergency medicine physician in New Jersey. Always good chatting with you. Thank you for bringing us some of those insights.
Thank you.
Welcome back to Yahoo Finance Live. We've, of course, been watching the latest numbers here on the COVID-19 front as cases continue to spike higher, as well as hospitalizations continuing to set records. And over the weekend, a closely watched model for COVID-19 deaths was updated to incorporate the upcoming vaccine rollout. And even with doses beginning soon, the IHME model projects the COVID death tally to top 500,000 by April 1st. And joining us now for more on that is Dr. Ali Mokdad, Professor of Health Metrics Sciences at the Institute for Health Metrics and Evaluation here, alongside Yahoo Finance's Anjali Kamlani. And Dr. Mokdad, I want to start with that model because, IHME has been putting out the model that even the White House has been looking at in terms of where this goes from here. You stress that because the vaccine's coming doesn't necessarily mean we're out of the woods by any measure. So talk to me about what needs to continue in order to bring that death toll down.
Good afternoon. The vaccine will help us, but on the long run, because they are coming a little bit later after the peak that we are expecting right now in December and January. So it's very important to remind everybody that the vaccines will help. Why we're seeing this surge right now, and we're concerned about what has happened during Thanksgiving, because seasonality and people are moving indoors, and the virus is more likely to circulate. What we need to do in order to contain the virus, basic preventive measures. Stay away from each other, wear a mask, and wash our hands. And if 95% of Americans wear a mask, we can save 66,000 lives between now and April 1st.
So let's talk about that number. It's a pretty significant one when you consider that mask wearing is recommended, but not necessarily mandated in a majority of states across the country. What's your expectation here on a federal mandate of mask wearing? You talk about the 95%. Is the expectation that with a federal mandate you can get to that number?
Yes, of course. We need a national mandate, and we need every state to have a mandate for people to wear a mask. Right now, what we are doing is we're confusing the public. When you have a place that says you need to wear a mask and another doesn't, so you're basically confusing the public. We need a consistent public health message. And we've seen in other countries where people wear a mask, around 95%, they've been able to control the virus much better than what we have done here in the United States.
Doctor, there's also been a lot of discussion about restrictions that are taking place across the country. So in addition to knowing that the vaccines are only going to be used with those high-risk individuals first, therefore leaving the rest of the population alone for some time, what are your thoughts about these restrictions and their potential impact as well?
So the restriction, unfortunately, we have to apply some restrictions because our hospitals are being overwhelmed right now with the numbers of cases. And the only way we can control this virus and not put pressure on our medical system is by putting in place some of these restrictions. We know that restrictions have a long-term effect on health, have a long-term effect on economy. So we have to be very careful, and they need to be the last thing on the table. So we're counting on the public again to wear a mask and do the right things in order to avoid further lockdown in the United States.
Dr. Mogdad, I mean, when we think about how hard it is to model this, I mean, it's been a tough year for any forecaster trying to figure out where we go. Even Dr. Fauci today was kind of stressing the idea that, you know, what we saw play out with Americans traveling and celebrating Thanksgiving might not still be baked into the data right now when we look at cases and how long, you know, the lag factor is here. So we know Christmas is coming as well, the holidays. I mean, how confident are you that the model right now, the IHME model, you know, what kind of variance are we expecting if things do get bad in terms of Americans not adhering to some of these policies over the holidays?
So in our models, we have two variables that try to account for that. One of them is the mask wearing, and one of them is mobility from cell phones. So when we notice mobility increasing, we see an increase in cases and unfortunately mortality. You're right. We don't know the impact of Thanksgiving yet. It's unfolding in this week and the next week. But for all of us right now, we can add these variables as we get them, and we can update our projections based on how people moved and how much they wore their mask or not.
And Doctor, we've heard increasingly from public health officials that the real spread right now is happening inside homes, in these gatherings that are happening. You talked about the restrictions that are going into place right now in places like California as something that's necessary, but how effective can something like that be when the restrictions are largely enforced in public areas, but the actual spread is happening in private homes?
Very good point. So in order to control COVID-19, we need the public to do their part and the government to do its part. So we've seen right now in California restrictions came into play. But at the same time, you're right. Now we're seeing a lot of infections happening indoors inside people's home. They get together and among their friends and their family member, and they feel safe. These are people who are not going to hurt me. They put down their guard and they take off their mask. So we need to be vigilant even inside our homes. And as you remember, CDC put recommendations for mask wearing even indoors among non-immediate family in your house. So we have to be extra careful even with our own personal behavior in order to contain this virus and not rely on the government itself. We, the public, have a lot of responsibilities right now.
Doctor, looking ahead, we know that a majority of the population is not going to get vaccinated until March or April, and deaths and cases will continue to rise until then. When do you anticipate, the number to slow down? What number of the population needs to be vaccinated before we'll see those numbers slow down?
The numbers will start coming down when the season change, warm weather, and people can move outdoors to outdoors activities. So we expect the peak to happen mid-January, and the cases start coming down after that, with the vaccinations coming into play. Sometimes in May, June, we can go back to our normal lives if Americans are willing to take the vaccine.
Dr. Ali Muqdad, Professor of Health Metrics Science at the Institute for Health Metrics and Evaluation at the University of Washington. It's good to talk to you today. Thanks so much for your time.
Thank you.
Ambulance operators say the country's emergency system is being pushed to the brink. To talk more about this, we're joined now by Dr. Ed Rock, Chief Medical Officer at Global Medical Response. That is a medical transportation company. So, Doctor, I'm hoping you can kind of enlighten us about the situation on the ground for those ambulance operators, and how is the pandemic worsening the situation, which some folks were saying was already pretty bad and pretty dire before?
Yeah, you're spot on. And the COVID pandemic has become the perfect storm for emergency medical services. So communities, the public relies on EMS. There are very few places in the United States where you can't dial 911 and have someone who's trained and very capable that comes to your problem in under 10 minutes. So we've relied on that to manage emergencies, to manage uncertainties, and then the pandemic hits. And this perfect storm of a highly contagious infectious disease, as we're learning about it while we're managing it, with the increased costs of personal protective equipment, frankly, early on, the challenges of making sure we had appropriate personal protective equipment, the training and education of our frontline caregivers, the operational changes, the either decrease in ambulance volume in some communities, which impacted revenue, or the dramatic increase, all of those variables create significant challenge for sustainability for EMS systems to continue to operate. The EMS professional, probably one of the best professionals on the planet, they want to get out and help. They want to make a difference. And now we're going into almost a year of a very challenging environment. So we're worried. And EMS infrequently is as worried as we are today about being able to sustain that as the pandemic continues.
So, Doctor, I'm reading that some, ambulance companies, emergency medical services companies are actually going out of business during this pandemic. Why is that? Because you would think that an increase in ambulance calls would actually make some of these companies more profitable. Why is that not the case here?
Yeah, it is a fascinating paradox. So one of the challenges with reimbursement in emergency medical services, and not a lot of folks know this, is that the reimbursement occurs when the patient is transported to the hospital. So those calls that result in a response of the EMS entity, the ambulance, where the patient is evaluated and not transported to a hospital, are not reimbursed. So as you know, during COVID, the healthcare system, very appropriately, by the way, really worked to try and minimize the number of patients who were transported to overcrowded hospitals that had saturated ICUs. So what happens with an increased number of no transports, revenues decline substantially. So the patient gets managed, but the EMS system, the ambulance, does not get reimbursed for that. The equivalent would be, imagine going to a physician's office and the physician really only gets reimbursed if the patient's admitted to the hospital. So the incentives there are to move the patient to the hospital. The challenge is that in an era of COVID, we really try and keep as many of those patients outside of the hospital as we can.
All right. Unfortunately, we don't have any more time here, Doctor. And I know that what you're highlighting here really kind of underscores some of the needs for more stimulus funds. I know that ambulance services do not receive as large a portion of some of those funds as many would think, but we're going to have to leave that there. Dr. Ed Rocht, Chief Medical Officer at Global Medical Response, would love to talk with you again. Thanks so much for joining us today.
Happy to do it. Thanks.
But I want to talk now about coronavirus. There's nearly 15.2 million cases of coronavirus in the United States, while the death toll has risen to roughly 287,000 deaths. Hospitalizations are rising as doctors start to see what they are describing as a post-Thanksgiving surge. I want to bring on Dr. Tyson Bell, Assistant Professor of Medicine in the Divisions of Infectious Diseases and Pulmonary and Critical Care Medicine at the University of Virginia. A very long title there, Doctor. So I'm very excited to have this conversation with you. I shouldn't say excited, but I'm glad to have you here with us for this conversation. You know, as we're starting to see these case counts rise, we're starting to see concerns over the virus rise with it. This is according to the latest poll from Ipsos. 60% say they are worried about the virus now. I'm wondering if you see that translating to any kind of changed behavior, at least when it comes to mask wearing and social distancing.
We certainly see a lot more concern in the community, and I think that reflects the fact that coronavirus is now very deeply spread across society. And we've seen numbers that, again, are very staggering, numbers I never thought we would see before, over 200,000 cases per day, over 100,000 in the hospital, over 2,500 cases per day. The sad thing about this is that we really haven't seen the peak of this. The post-Thanksgiving surge that we expected still is expected to go on another week or so, and we're going into Christmas. I have seen a lot more concern in the community for sure, but amongst our staff as well, because we're seeing people with families who are getting infected, and it seems like every day it's getting closer and closer to people that we know and love.
Now, this poll also said that about 20% of folks are engaging in risky behavior like gathering indoors. Wondering what your thoughts are on that, and if we can fight this pandemic with a minority of Americans continuing to engage in these types of activities.
Well, we know the nature of the virus is that it spreads, and it only takes a small number of people to have what we call these super spreader events, where it can spread widespread through an indoor closed setting. That's a setup for it. And then you go back to your home, and in-home transmission drives over 50% of the infections in the country. So this is very risky behavior. We have to keep getting the message out that it's time to really lock down and not go places unless you absolutely have to. Wear a mask, absolutely, physical distance, and wash your hands frequently. We're coming into Christmas, and I think, unfortunately, unless there's you have a member in your household there already, Christmas should be virtual this year.
So I want to pivot now to what is a little bit of a happier news or happier outlook, which is the vaccinations that have already started in the United Kingdom. The authorization of Pfizer's vaccine largely expected soon from the FDA, which means that Americans can expect to receive a vaccination, at least hopefully before the new year. But there's been this allergy warning attached to the vaccine. I'm wondering if you guys are worried as doctors that this could put people off taking the vaccine here in the United States, especially if people are getting sick, especially given the wariness that we've been seeing people really talk about when it comes to this vaccine, particularly here in the United States.
Well, first and foremost, I would say that transparency in this process is of utmost importance because a lot of the concern has been around this has been very fast for vaccine development, and we're not sure what the data actually shows. We do have some data from the Pfizer trial, and we have this example from the UK. These were two recipients who both had severe allergies, enough to the point where they actually carried around EpiPens just in case. So a very different sort of predilection to having allergic reactions. I think what's important to remember is that in the actual trial data, hypersensitivity reactions, so things that approach allergies or allergy-like symptoms, were very, very rare. We're talking way less than 1% in the population. Thousands of people were vaccinated yesterday in the UK. And just for context, 1 in 1,000 people have died from COVID-19. Luckily, the two people who had the severe reactions, they're recovering well. They were in a healthcare facility at the time. So I think it's appropriate to have some caution for people who do have these severe reactions to that sort of extent. But by and large, this is a safe and very effective vaccine. I'm actually scheduled to take this vaccine on the 15th of this month, and I'm going in with absolutely no reservation.
Well, I definitely am going to want to have you back after you receive that vaccination to at least do some myth busting. I know some folks are a little bit worried and a little bit anxious that they're going to be feeling some pain or something like that after some of the shots, after we've been hearing some rumblings of folks reacting to this vaccination. I want to ask you about some of the data that we've been getting, and you were hinting at it a little bit earlier. So the FDA, obviously, as I mentioned, considering authorization of this vaccine, the Pfizer vaccine. But AstraZeneca, so far, is the only company who's publishing their data in any kind of peer-reviewed journal. The data that we've gotten from Moderna and Pfizer have been released to us in press releases. I'm wondering how necessary you think that step is of releasing that data in a peer-reviewed journal, or if, the FDA analysis of the data, of the efficacy, of the side effects, et cetera, could be enough.
Well, it is a very unusual way that we're having data released. So the usual process where data is peer reviewed and then released, and then there's a press release, just can't happen in this age where the virus is spreading so rapidly. We have to get data out there. So in addition to the AstraZeneca trial, the FDA submission was a 53-page document that I reviewed yesterday that went over a lot of the trial data. And I was satisfied with what we saw as far as efficacy and in the low event of adverse events. So we're going to get this data as it comes out, but important to remember that there are 3 independent bodies that are looking at this data pre-release when it gets peer-reviewed and released in a journal. That's the Advisory Committee on Vaccine Practices, House, and the CDC. These are the independent review committees that are set up for these trials. Each trial has an independent board that's looking at this data, and the Vaccine and Biological Related Products Advisory Committee that's housed in the FDA. These are all people that are experts across the country, across the world. They have no skin in the game when it comes to trying to get something rushed to market that may not be safe or effective. They're going to absolutely make sure that it works. And assuming that they approve it here in the US, then I have full confidence that it's something that we should take.
All right, Dr. Tyson Bell, Assistant Professor of Medicine at the University of Virginia. It is always great chatting with you, Dr. Bell, but as I mentioned, I look forward to the day when we can have some happier conversations. Thanks for joining us today.
Me too. Thanks for having me on.
Let's turn now to coronavirus in the United States. It's now risen to more than 15.4 million cases, positive cases of the virus in the U.S. And the death count has also ticked upward to nearly 290,000 deaths. That's all according to the Johns Hopkins University COVID-19 tracker. Yesterday, we saw a record number of deaths. More than 3,100 people died from the deadly virus. So let's bring on Dr. Nada Fadul, Associate Professor of Infectious Diseases at the University of Nebraska Medical Center. Doctor, so we're seeing cases rise, we're seeing these death counts rise. How much longer do you think that this virus is going to be a runaway train?
Yes, thank you for having me. Unfortunately, these numbers and high mortality that we're witnessing right now is not surprising. There's so many factors that contribute to this. Some of them are out of our control, such as the weather, but there are some factors that we have control over, whether that is citizen responsibility, whether that's
federal responsibility of having a nationally coordinated response to combat this pandemic. We're seeing variable responses across states, and that's really augmenting the problem that we're seeing right now. Many states did not implement directive health measures that will combat the spread of this virus. And with the travel and the spread that we've seen through Thanksgiving holiday, unfortunately, this will continue as we face a similar pattern during the next holidays.
What about restrictions? I'm wondering if you think that we're doing them properly. A lot of folks are saying we should not be closing schools and allowing restaurants to be open. So what should we be shutting down? What should we allow to stay open? And do you think that states need to be more restrictive on what activities are allowed to remain operational?
I think there are many evidence-based strategies that we know are very effective in combating the spread of this virus. We know masks do work to hold the spread, so states really need to take that seriously of implementing statewide mask mandates that will hopefully restrict the spread, but also unnecessary gatherings need to be taken into account. Many states have open restaurants, open places, public places. They don't have restrictions of the gathering numbers in these places. So that also needs to be taken into consideration. And unless we have a federally coordinated national response that takes into account making sure all the states, follow this national response, then we're going to see this variability because there is movement between these states. People are traveling, they're going to continue to travel, and unfortunately, that's going to lead to widespread spread during the holidays as well.
So we do have this vaccine candidate from Pfizer. It's looking to be analyzed today, scrutinized by the FDA in advance of receiving, hopefully, an emergency use authorization. I'm wondering if you're scheduled to take the vaccine as yet, and what are some of your biggest concerns about this vaccine right now?
Well, we're all anxiously awaiting the decision from the FDA. We're really hoping for an emergency use authorization of the vaccine, but there are many concerns that need to be taken into consideration when the vaccine is made available. So first of all, we know there are not going to be enough doses, especially for high-risk people, including healthcare workers, including essential workers, including older adults, those with high-risk conditions. There are only going to be 2.9 million doses available right after the authorization, and that's just not enough. And we don't really expect manufacturing to be able to keep up with the numbers of patients who need to be vaccinated. So that's one of the concerns that we need to keep in mind. This is not going to be an immediate solution to halting the spread. The other big concern that many of us have in healthcare is that we really need to make sure we have effective ways to make sure we reach minority populations who have been highly impacted by this pandemic, such as African Americans, Latinx, Native Americans, who have almost 3 times the risk of death of this virus. And we need to build trust in those communities in order to ensure uptake of the vaccine. And that's really need to be taken into consideration. It's just not the authorization, but also the distribution and the equitable access to the vaccine. There's also the concern that this is going to give a false sense of security to the public, knowing that there is a vaccine. We know that it's going to take months before we reach the majority of the population. This is not going to be something that's done overnight. We're expecting by February, we're only going to reach 30% of the U.S. population. We really need to reach a much higher. So
folks still need to make sure they maintain social distancing and keep those restrictions in place before everyone gets a vaccine. All right, Dr. Nada Fadul, University of Nebraska Medical Center. Thanks so much for joining us.
Thank you for having me.
We want to talk about COVID-19. We're going to do that with Dr. Kamara Jones, former president of American Public Health Association. Also, it's important to note that we're waiting any minute now that advisory panel, the outside experts, 23 of them, to recommend to the FDA the emergency use authorization of the vaccine from Pfizer. And Walmart is now saying that they'll administer COVID-19 vaccines once they're approved. Dr. Jones, help us understand. We hear all of this good news, but it's going to be a long time before many of us ever get an inoculation, correct?
That's correct. The panel that advises CDC said that the Vaccines should first be made available to healthcare workers and those who are living in long-term care facilities, mostly nursing homes and the like. And they're expecting at most 100,000 doses in December. But you remember, everybody needs 2 doses. So that's 50,000 people. That doesn't even cover our medical care workforce. It's going to be through the spring.
Through the spring. Let's talk about this, because we're also seeing disproportionate numbers of people impacted by COVID-19 and dying from COVID-19 in neighborhoods and communities of color. And has anything been done to alleviate the suffering that we see around us?
Well, so your question makes me want to let everybody know we are never going to vaccine our way out of this pandemic. What we have to do is fully implement the public health strategies that we have not in this administration implemented at all. On the individual level, of course, there's the mask wearing, washing your hands, keeping your physical distance, all of that. But the government needs to make it feasible for most of us to safely shelter in place, especially right now with the virus raging like a forest fire. So we need income supports, maybe a basic, a universal basic income, or at least what was called before a stimulus check, which is really a safety check. We need to make it safer for people to stay in homes with an eviction moratorium. And when people do have to go to work, not for the profit of others, but when they really are essential in the health workforce or transportation or food production, then we need to fully protect them with PPE and workplace safety standards and all of the like. So what we need to do is understand the vaccine is hopeful, but that is not the solution to this problem right now. We have a public health crisis that we need to treat with public health strategies.
When you hear news like Walmart announcing that they will administer the vaccine, I'm not up to speed on whether we have to pay for the vaccine, whether it's Walmart or CVS. But what do we know about this, and what do you think of them doing that?
So some of the most of what I've heard is that people are going to try to make the vaccine free, but I'm not sure where that's written. But my assumption has been that the vaccine would be made available free of charge to people.
And I would imagine you welcome pharmacies like Walmart or stores like Walmart, and eventually CVS, Walgreens, administering these. They already do the flu shots, right?
They're already signed up to administer these in the nursing homes. So there's already been an agreement that it wouldn't be that the nursing homes would have to get their people out. So the pharmaceutical companies and the like are already, not the drug stores are already on board to do that kind of thing. With the 2 first vaccines that are likely to be approved, those are the ones that require deep freeze storage and the like. And, you have to do all of this fancy stuff about diluting it. And then it's 5 people can get it from 1 vial, and you can only store it in the refrigerator for a few hours. There's a lot of those kinds of mechanics that have to be worked out. So it's good if a big box store can work that out. We also have other vaccines that will be coming behind that won't require that kind of deep storage. Some of the other vaccines that will require only 1 dose. So we're just at the start of rolling out vaccines. It's good to have the Walmarts and the others. It's good to have local health departments involved. It's going to be good to have the hospitals. Perhaps it'll be able to be done through community, federally qualified health centers or churches and the like. We're going to be need to get it out to people where they are.
Dr. Kamara Jones is the former president of the American Public Health Association. I hope we can have you come back after the Biden administration takes its role in D.C. to talk more about the need for a Secretary of Equity. Unfortunately, right now we are out of time. So all the best to you, Doctor.
Thank you.
Coming up, Disney's Big Investor Day later this afternoon. Dan Roberts is going to join us to explain what he's watching as Disney goes deeper into streaming. We're back after this. We're going to bring into the stream Dr. Lakshman Swamy, ICU physician at Cambridge Health Alliance. It's good to have you here. I want to start with this. The White House ordering the FDA chief to authorize the vaccine by the end of today. Does this really speed anything up? I believe the expectation was that those who were going to get it would start getting it next week, right?
I mean, I think that that's kind of more of a political move than anything else. So I don't know what to say about it. I think, all the signs are that we're going to be moving forward with this. We've already seen other countries move forward with it. And I think as a clinician, and I think I speak for many of my colleagues here, we feel pretty good about the safety and efficacy of this vaccine from how much we know. And I think really at this point, the risks of letting this virus kind of just go on unchecked are far outweighed by the benefits of the vaccine. I think it's safe enough, and I think we got to move forward soon.
Dr. Swami Anjali here. On that point, though, I know that there have been some concerns about not knowing whether or not pregnant women, individuals with allergies, and other concerns. That seems to be what's in need right now for the FDA to sign off. What are your thoughts on what that will be?
I think that having a wife who was pregnant recently, I'm very sympathetic to that. I think if we had everyone vaccinated except people who were pregnant, except people under the age of 17, that would be a lot of people. And I think it's worth moving forward. I don't want to leave anyone out. I think it's really important to think hard about that. But there's probably a way to kind of not have either or here and to move forward with safety and bring people in as we can.
What would you say to the people who are concerned about the safety of the vaccine itself? I mean, the Pfizer vaccine and the Moderna vaccine are not even based on live virus. So does that remove any kind of threat at all to the human body?
I mean, certainly using something that's based on live virus to me is always going to be more risky. There have been cases in the past where live virus has been injected. I think from my perspective, people have very good reasons to be hesitant about getting a vaccine. That's because, in large part, the people who are hesitant are some of the most vulnerable people when it comes to coronavirus. These are Black and brown patients who've been discriminated against by the medical kind of industry and healthcare system for a long time. I understand why people are hesitant. At the same time, it's our job to bridge that gap and to be able to say, hey, I'm your doctor, and I think this is safe for you, and I'm really thinking about you and your loved ones here.
Dr. Swami, pivoting really quickly to the news out of New York that indoor dining is going to be closed once again. It seems like we're in this cycle, which is something that experts like yourself have already predicted. Is this something that we can see continuing into the new year, possibly until March, April, sort of this back and forth until the vaccine starts getting to the general public?
I think the key point there is the vaccine getting to the general public. In Massachusetts, we're expecting that to happen maybe in the spring. And what that means is that come the spring, we don't expect to have anything close to herd immunity in Massachusetts. And I think that's probably true across the country. So we have to be very careful about acting like we have herd immunity before then. And that goes for our policy making as well. So I think that we are really in this for still the long haul. We have to look at this winter and say, what's the right thing to do? The right thing to do is to really hold back a little while longer. Don't go make that big indoor gathering happen a little while longer. It's going to take us many months to roll this vaccine out and get enough people vaccinated for it to really count.
We're also going to have different vaccines, we all assume, by the time in spring that the general population can get them. There's Moderna. We're going to get Johnson & Johnson's results. I think we might start hearing results on Johnson & Johnson's vaccine in January. Once we have massive amounts of vaccine available, would it make sense to just have the general population report to vaccination centers, say, based on zip code? Or is it better to let the pharmacies and each individual doctor coordinate with the population?
Maybe it's not an either or, maybe it's a both, because I think that the trust that people have in their local communities and their community physicians really matters. And I think that's going to be the way that we get to a lot of people. On the other hand, that's not necessarily something that we can scale rapidly and get the most vaccines to the most people as fast as possible. So I think we're going to need to be very thoughtful about how we approach this to really get vaccine to people, to everyone.
Doctor,
Anjali?
finally, I know that one of the debates yesterday at the Pfizer vaccine advisory meeting was about Pfizer's results, and I've heard different opinions on this. I wonder what yours is about the idea that Pfizer's could turn into a one-dose vaccine just based on the results after the first dose. I also heard that that's not exactly the way it functions based on how the body is primed and learns to defend itself. So I wonder what your thoughts are on that.
I think what's amazing about this is that, we don't have that much experience with mRNA-based vaccines, so it's very exciting. From a scientific perspective, this is an incredible moment where we're seeing really new sort of vaccine technology moving forward. That said, could things be better than we think they are? Sure. We have very little data in a sense compared to what we will have in the months from now. So hopefully things are a lot better than we expect, but I wouldn't plan for that. I would plan based on what we know right now.
Dr. Lakshman Swamy is the ICU physician at Cambridge Health Alliance. Look, if you can survive driving on Storrow Drive in Boston, you can survive this. All the best to you, and thank you so much for joining us.
I want to turn now to Dr. Heather Yo, SurvivorNet medical advisor and associate professor of surgery and population health sciences at Weill Cornell Medical College. Dr. Yo, thanks so much for joining us today. So if the FDA authorizes this vaccine, possibly tomorrow, as Anjali was mentioning, we could see this start rolling out next week. So I'm wondering, now what? All right. Is your hospital ready to start distributing this vaccine next week? Are your friends and coworkers at other hospitals, are they ready for this distribution?
Yeah, everyone's actually ready. We've been prepared. We have plans. Our administrative teams have met and talked about how we're going to roll it out, exactly where it's going to go. And I think that we're looking forward to and hoping to get the vaccine out next week.
So this vaccine is really coming, it seems, when it's needed the most. We had a record number of deaths earlier this week. That was more than 3,000. As I mentioned at the top of the show, we had the second worst day in this pandemic when it at least comes to that positive case count in just one day, over 200,000 yesterday. Is this the worst that we're going to be seeing now?
It's hard to say. I will tell you, in New York, the worst hit us in March. Our hospital is not nearly as full as we were in March. I do think that we're going to continue to have a post-Thanksgiving increase. And a lot of it will depend how people act over the, next couple of weeks and holidays.
I'm wondering if now that we have this vaccine, if businesses can really start to think about reopening anytime soon.
I mean, it's really hopeful. The problem, as you know, is what amount of vaccine we're going to get. We expect probably the first wave, as you mentioned earlier, is going to be healthcare workers and people that are dealing with patients on a frequent basis. So, example, emergency health responders, our firefighters that are and our ambulances that are going to patients' homes to pick them up. They certainly need to have access. And then it's going to go to the nursing homes because we know disproportionately, less nursing home patients have gotten sick, a large amount of them make up a high number of deaths. And so going to those higher risk groups is going to be important. But as you know, vaccine production, we don't exactly know. Both companies have told us they'll probably get a total of, 50 million vaccines. But we are trying to kind of figure out how that's going to roll out. The vaccine is difficult to distribute. It's hard to store. But our institution, I know we've had calls on it over the past week, is prepared, has the proper storage. We have distribution set up, and they've kind of told us what order we can expect to be getting our vaccines in.
Are you signed up to get your vaccine, doctor?
We haven't actually signed up, but they've told us what order we're getting them, and I am certainly, as soon as I'm on the list, I'm signing up.
I want to ask you about restrictions that need to be in place while this vaccine starts rolling out, because I think a lot of people believe that, once this vaccine starts rolling out, it's like a light switch in the United States. Everyone can start going back to the bars, to the restaurants. They can start seeing their friends and their families, even if they have not yet received the vaccine. And we do have the news from Governor Cuomo that indoor dining in New York City is now going to be shut down. So I want to ask you what that plan needs to be going forward in terms of restrictions restrictions. If more cities should consider following this move, shutting down indoor dining and placing more restrictions, at least on some of these businesses, even as the vaccine is being distributed to folks?
Yeah, I mean, first off, the vaccine takes a little bit of time to work. We know that after the first dose, there is some efficacy, but it really takes until that second dose. And for the Pfizer vaccine, that's 3 weeks later. For the Moderna vaccine, that's 4 weeks later. But it's going to take until the second dose and sometime after, so your body builds up its immune response till it's actually safe. There's also some questions about whether or not, well, you wouldn't get sick necessarily after an exposure. Even if you're vaccinated, there's a potential that you still might be a partial carrier to the virus. So a lot of it's going to depend on how quickly we can ramp up speed, how quickly we can get people vaccinated. I mean, it's great that this vaccine is as efficacious as it is. They're estimating, as mentioned from the Pfizer data, 94%. But part of the question is going to be what percent of the population gets vaccinated. As you mentioned, there are some restrictions. As is standard for vaccines and most clinical trials, we usually don't test them on children. We usually don't test them on pregnant women. And so some of these have been restrictions. In addition, a lot of people, because they're afraid, are afraid of the vaccine. And I think that encouraging people, and I mean, I've talked to a number of vaccine specialists. I've talked to a number of epidemiologists. This is one of the safest vaccines we've seen. I mean, the trials have really shown a very low profile. But as you mentioned, this is a preliminary approval. It's not final approval. It's an emergency use authorization. You can't actually get full approval until we have a full 6 months of data. And Pfizer's expecting to apply for that in April at some point.
You know, we've had a lot of doctors and public health officials come on this program and say that they're deeply worried about the potential missteps, that will happen with the Trump administration handling this distribution. I'm wondering if you share some of those concerns.
I mean, I'm a physician. I'm not a supply chain management person, but I will say that, you know, most of what's happened has been left to the states, and our state has a plan. I'm in New York. We've had an independent advisory council that's actually made sure that the data has been checked. I know members of our faculty have been involved with kind of looking and overseeing some of the safety data. And I believe that, you know, as these organizations are getting ready to distribute, we're hoping to do it in a safe and sound manner.
How long do you think it'll take before everyone in this country is vaccinated, or at least until we have some level of herd immunity?
I mean, I think that, you know, a lot of it depends on both the Pfizer vaccine, the Moderna vaccine, the AstraZeneca vaccine, which, as you know, probably has the most potential for reproducibility. I think that the estimates of April, May are probably what we think are most likely for the majority of people who want a vaccine to have one.
Right. All right. Dr. Heather Yo, Weill Cornell Medical College, thanks so much for joining us today. I want to turn now to Dr. Louisa Petrie, Assistant Professor at Mount Sinai School of Medicine. Doctor, thank you so much for joining us today, especially on this day that we get this exciting news that the coronavirus vaccine is starting to be distributed. I wanted to ask if you've signed up to receive your vaccine yet, and give us a little bit of details about how Mount Sinai is, if they're ready and prepared to start distributing this vaccine.
Christine, it's indeed a historical day, but it's also full with mixed emotions because as we are getting the vaccine, first one in the United States in someone's arms, in the same time we have a milestone of 300,000 cases. That's very grim. But going back to Mount Sinai and the question, if I received the vaccine, first of all, I was a participant in Oxford trial, so actually I'm going for my second dose on Thursday. Regardless, the hospital has sent us emails that will be notified when our turn is coming. I was notified also that Mount Sinai Hospital received, as we speak, at 1 o'clock, the first delivery of vaccines. Keep in mind, they come in big packages. They have 90 seconds to unpack them and make sure they are stored at the right temperature. The pharmacy department is overseeing that, and they are assigning them in a hospital algorithm First, it goes to intense touch points with COVID healthcare providers.
So, Doctor, you're actually the first person that I've had the pleasure of speaking with who's actually received this vaccine, or at least part of the dose of the vaccine. I'm wondering if you could tell everyone what that experience was like. We've heard news that some people had, really bad symptoms. They had a not so great reaction after they had the first shot. What was your experience like? Did you experience any, pain, fevers, aches, chills, or anything like that after you received at least the first dose of that vaccine?
Kristen, first of all, I don't know if I received placebo or not, and I was involved in another trial, not Pfizer. I was in AstraZeneca Oxford. What I hear from most of the people is that Pfizer might have a little bit more side effects than the other ones. I personally only felt for 3 days a little tenderness at the site of injection. But again, I'm not sure if I received the placebo or the real vaccine, as this is double-blinded. So
I'm wondering how quickly and how effectively you think the United States can distribute this vaccine. How many people do you think we could have vaccinated by the spring, for example?
As per the head of HHS, Alex Azar, he is looking optimistically of vaccinating around 40 million people by the end of the year. And 40 million doses, that would mean 20 million people. And looking at 100 million people by the end of February to be able to open to the general population by March. However, this is a very optimistic expectation. Most likely, we're looking at the second quarter for the general population.
Who shouldn't take this vaccine right now? Can just anyone take it, or are there still some concerns, especially about children taking this vaccine right now?
Indeed, Kristen, there are a few groups that we don't have enough data. The fact that it's not recommended doesn't mean it's harmful. It just means we don't know yet. They agreed that anyone older than 16 is safer to receive it. Also, they are running sub-trials right now as we speak in children above the age of 12. So very soon we might have information on them as well. When it comes to pregnant or lactating women, the recommendation is to be discussed with the healthcare provider. They did have a few patients who became pregnant between the doses during the trial, and nothing has happened to them. However, the risk and benefits have to be taken at an individual basis, because what if a nurse becomes pregnant and she works in the ICU? That's a different story than someone who can work from home for the next 9 months. Another recommendation to avoid vaccine at this point is for those who are immunocompromised and those who have a history of severe allergic reactions. Again, those have to be decided on individual basis.
I feel like the one question I keep hearing, from my friends, family, just other people, is that they don't know what the long-term effect or impact of this virus can be, of course, because it hasn't been studied over the long term. I'm wondering how founded or perhaps even unfounded some of those concerns are. If you see anything in this vaccine that really might be dangerous, at least over the long term.
That's a great question. And to demystify all the misinformation out there about vaccine is going to be our next big hurdle, because vaccine hesitancy is a severe virus on its own, and it can impact how much people will accept the vaccine. But answering your question, historically, most of the vaccine side effects occur in the first few days. There is no evidence yet there are long-term implications. That's number one. So we are totally out of the window when we look at these trial participants. So most side effects occur actually in the next few days after vaccination. They are mild, they're related to building and ramping up an immune system. And I would look at that as good news. That means, yes, I'm responding, I'm becoming immune. I would celebrate, actually. Just take one Tylenol and move on. But secondly, the concerns comes because they think that vaccine was developed in such a short time, and we don't know enough about it. But actually, this vaccine has not been developed overnight, has not been developed in the last 10 months. This technology has been researched for the last 20 years. So we have a lot of evidence behind what is new right now. We just took that technology and tweaked to be applied toward COVID. So that's reassuring. Actually, it's not something completely new.
So, Doctor, I want to ask you about something that you actually wrote in your notes, which is that we cannot lower our guard right now. I'm wondering how bad this winter can get, especially as we do see some folks getting vaccinated against this virus. But we also, of course, have the holidays coming up. And I think people are really getting tired of the fact that they can't see their friends, their family, their loved ones, and are getting a little bit itchy, to get back out there and enjoy their lives. What is the danger if folks really start to do that going forward?
Christine, this is really my biggest worry at this time, because we see good news on one side. It might make some people relax and lower their guard. And now we are heading into the most wonderful time of the year, and could become the most dangerous time of the year. The young people and those at risk, general population, they'll not see this vaccine in the next 2-3 months. And we're actually heading into a dark winter. The tunnel is long and it's dark. We have light at the end of a tunnel, but we still have to cross this bridge safely, make sure we're not falling off the cliff during this transition period.
All right, Dr. Louisa Petri, Assistant Professor at Mount Sinai School of Medicine. Thanks so much for joining us today.
Thank you.
We want to stick with this, and for that, we want to bring in Dr. Stephen McDonald. He's an emergency medicine physician with New York Presbyterian. And Dr. McDonald, great to have you back on the program. This is clearly a very historic day. What can you tell us I don't know what extent you're able to talk about this, but what can you tell us about how your hospital is handling the distribution efforts? And have you also had your own shot yet?
Absolutely. So, the details around distribution are still relatively opaque, but we have been told that we're going to be getting the vaccine at some point this week, and that it will be distributed through the emergency room. So I, for one, am extremely excited about this. This is the beginning of the end, I think, for the coronavirus.
And so you will be getting your shot presumably this week or next week. Is that what we're hearing?
That's the hope. It could be as early as tomorrow. So we'll see. But unfortunately, I don't have solid details on the exact timing of delivery.
Dr. McDonald, it was encouraging to hear you just say a couple moments ago that this is the beginning of the end. And it's great news when it comes to the vaccine. But what are you seeing right now just in terms of the virus spread, and what you're seeing in your hospital just about your capacity limits and how you guys stand at this point?
Absolutely. So numbers in New York State are extremely concerning. What I'm seeing on the ground, there's definitely more coronavirus, more sicker patients than we had throughout the summer and early fall. That said, we're nowhere near where we were in New York City in end of March and early April, which is somewhat hopeful.
Regarding this vaccine, so you get the first shot. How much protection does that give a person before they get the booster? Do you need both shots to have the 95% efficacy, or does one shot protect you until you get to that second?
So the studies that refer to the 95% efficacy rate, those only refer to patients who have received both shots. And so with the Pfizer vaccine, that's at 0 days and 21 days. With Moderna, it's at 28 days. That said, it is thought that the first shot does confer some protection, but that does not nearly approach the 95% efficacy that we're speaking about and that you're seeing in the press.
So, Dr. McDonald, it protects you once you do get the vaccine, but we don't know just about what it does in terms of transmission. So what does that mean for people who do get the vaccine once it's rolled out to the general population? Should they still be wearing masks? Should they still be social distancing? What type of measures should we be taking just so that we are cautious and make sure that the virus doesn't continue to spread?
It's a great question. So yes, we should absolutely all continue wearing masks even after we get the vaccine. And my hospital, for one, has already made that a policy that we're going to enact. And that should be a policy throughout the United States. People who have been vaccinated can still potentially spread the virus, even if they themselves do not get sick or do not need necessarily a hospitalization.
Doctor, I want to take a step back, and I think all of us were watching television this morning when the nurse on Long Island got that first shot. What went through your head when you watched that, if you got a chance to see it?
I did get a chance to see it. If I'm being honest, I'm a little jealous. I really can't wait to get my shot. I'm just so excited that the scientific community has come together and gone from taking this previously unknown virus and discovering a vaccine for it, and done it in a safe way and in a way that I, as a physician, can feel really excited about and honestly can't wait for. So yes, it's really exciting, and I'm incredibly hopeful about the months to come.
Has this helped raise the spirits just amongst you and your colleagues, just the fact that it seems like the end may be in sight now, or there's light, I guess is a better way to say it, there's light at the end of the tunnel?
Absolutely. I think spirits are raised. That said, there's still a bit of caution as we watch the rates rise across the United States. We watch the hospitalizations rise. And we know that the vaccine is going to take some time to be delivered to the most vulnerable patients. So, I'm cautiously excited. I'm ready. There's definitely a light at the end of the tunnel, as you said. But at the same time, there's going to be some difficult weeks ahead before we have this fully unrolled.
And you're referring perhaps to the fact that Mayor de Blasio here in New York City has said we may have a full lockdown. I'm not sure the timing, but it sounds like it's coming soon. Any sense of how long we would need to lock down this time around, since we are not going through the same kind of spikes that we had back in March?
Sure. So once you take a public health action, we see then the cases fall around 2 weeks after that. And then hospitalizations and death rates fall around a couple weeks after that. So the hope would be that, if we take an action in the next week or 2 weeks, we would know in the next month or so whether or not that's been effective and if it would have to continue or not.
Dr. Stephen McDonald, always great to have you on the program. We know you're extremely busy, so we really appreciate you taking the time. Emergency medicine physician with New York Presbyterian. We hope to talk to you again soon.
Always a pleasure. Thank you.
The number of deaths from COVID-19 now topping 300,000. And the picture is especially grim in rural America. We're now seeing North Dakota and South Dakota reporting the most deaths per capita in the last week. Let's bring in Dr. Benjamin Aker. He's president of the South Dakota State Medical Association. Dr. Aker, it's good to talk to you. We should point out, even with those deaths, we have seen a decline in the number of cases in South Dakota. Give me a sense of how things look for you on the ground right now.
Well, we're very happy to see a decrease in cases, but we know that the deaths lag after that. So it could be a couple weeks before we see that go up. And that's what we're worried about right now. I work in the emergency department. I'm an emergency physician. And, there's a big concern that those of us have in the emergency department of what could happen if we get that deluge of patients who are sick and some that are very sick. And if we get them all at the same time, that might overwhelm the hospitals in South Dakota.
And Dr. Aker, not just that, but also on top of that, the second wave potentially that could stem from, the follow-on to the Thanksgiving family gatherings and now Christmas as well here. When you look at that expectation and where hospitals are at in the state, how stretched do you assess things are at the moment?
Yeah, right now we feel like we have a handle on the minute-to-minute time frame of what's happening. We can take care of our patients that come in the door, and we can get them into the hospital or the ICU if they need it, and hopefully save their lives of those that we can. The concern, as you said, with Thanksgiving, if people got together, if a lot of people came together and brought coronavirus with them and spread it to their families and then out into the community, then that could then take a while for them to start getting sick enough to have to seek the emergency department. So we're cautiously optimistic that people will have taken our recommendations and will take our recommendations for Christmas. But we're also preparing for the worst, which is being inundated with patients that could be coming in.
And doctor, we're getting these grim numbers, of course, at a time when there seems like there's some optimism, the light at the end of the tunnel, if you will, with the first rollout of those COVID vaccines yesterday. Give me a sense of what the challenges are on the ground in the rural parts of your state. We've heard more and more about the challenges, the need for some of these freezer facilities, that second shot being more of a challenge because patients are going to have to drive back hours to get to a hospital that can get that.
Yeah, so the need for the refrigeration, that's a big challenge. Right now, we've by we I mean the state of South Dakota has done a lot of work into deciding who should be the ones to get that first round of vaccines. There's been a lot of talk about that. That will go to the frontline workers and some of the long care facility residents. Beyond that, when we start talking about giving that vaccine to general population, there will be some logistical hurdles because that vaccine will have to travel long distance to get out to the rural parts of South Dakota so that it can be given. And as you said, it needs to be the current vaccine that we have will need to be given twice. So those patients who are able to get that vaccine may have to travel twice to be able to get it.
And Doctor, I mean, the governor of South Dakota has been pretty outspoken about not returning to lockdowns there, batting back fears that it might have to happen if things do turn south later on in December or even in January. And I mean, that's something we've seen globally here as Germany steps up its lockdown there for the holiday season as well after they weren't able to get a handle on cases. What do you think the percentage chances are that some states like yours might have to return to those if things don't improve?
Well, South Dakota was never in lockdown for the entire coronavirus pandemic. The governor had not issued a lockdown. There has been some local pushes to have a mask mandate. The State Medical Association, of which I'm president, is in favor of a statewide mask mandate. We do not have that in South Dakota. Our governor has said that she will not be or is not able to, or doesn't have the authority to give a mask mandate or to lock down South Dakota. I don't know the legal ramifications of that as a physician, but we do not anticipate having that in South Dakota, and that may cause us problems.
Even with those challenges that you point out, you have been able to bring your case counts down about 27% over the last few weeks. You also have hospitalization down. What do you think has contributed to that decline, especially when you consider exactly what you pointed out? In the face of the surge that you've seen in the state, there wasn't a whole lot done to really try and stem the flow of the virus.
In the medical association, as physicians, we realized that we needed to take that frontline role in educating the population about the risks of the coronavirus and the things that they needed to do in order to help to limit that spread. You know, that's the hand washing, that's the physical distancing, and that's the mask wearing. And so we took it upon ourselves, and ourselves among 40 other groups got together and started a Mask Up South Dakota campaign in late October and had press release, and we've had a lot of advertisements. And a lot of this group is from various organizations, trade organizations, and various hospitals and health systems in South Dakota. We've all come together to say, okay, if we're not going to have a mandatory mask wearing, then we're going to rely on each individual person to take that personal responsibility to protect yourselves, your family, and your community. And I think that we're having a good effect now.
And Doctor, I mean, when we talk about how the vaccine rollout is going to go, Akiko was asking about, you know, the struggles about distribution. When you look at the population in North and South Dakota, it's something our viewers have pointed out, roughly along the same lines as Manhattan. In terms of concentration of people, it's very different across the states. So talk to me about that in terms of maybe what it might look like in some more rural states and getting it out and making sure that everyone can get this, quickly and not have to struggle with driving a lot of distances. What's it going to look like and what needs to be done there in some of these more, less densely populated states to make sure it goes smoothly?
Yes, I'm not the one who makes the decisions on that, but my recommendation to those who are would be that we need to have as many sites as possible that are able to refrigerate the vaccine and to be able to give that vaccine, to administer that vaccine to general population. So we need to have these sites spread out into rural South Dakota. Now, each one of those comes at a cost, and I don't know what that cost is. So I realize there's a lot of logistical things that need to come together for that. But the important thing is to try to make it as easy as possible for people to get that vaccine. That'll go a long way to getting the amount of patients together that we need to have vaccinations in order to get that so-called herd immunity.
And Doctor, even with that plan in place, the next step, it seems like, would be convincing the public to actually get the vaccine when it is available on a larger scale. How do you build that confidence?
Well, a lot of it is by showing those of us who are going to be vaccinated that when we're getting the vaccination, to be able to tell people how it was. Did it hurt? Was it easy? Was it difficult? Those kind of things. And I plan when I get vaccinated, and that's going to be hopefully this week as an emergency physician, to be able to publicize that to the population of South Dakota as much as possible. I presume it will be easy and painless, and I'm looking forward to getting that, because that is the best thing I can do at this point to help my community. And if I can portray that to the population as a physician, and if I can get the population to speak with their physician and to get that best information from their physician, that's the best way to get people to take the vaccine.
Yeah, certainly a long road ahead there. Doctor, it's good to talk to you today. Dr. Benjamin Aker, president of the South Dakota State Medical Association.
Thank you.
I want to bring on Dr. Daniel Griffin, Pro-Health Infectious Diseases Chief and a national process expert for vaccine administration at the healthcare company Optum. Doctor, thanks so much for joining us today. So now that we have not one, but two vaccines that are likely to be receiving this emergency use authorization once Moderna gets that rubber stamp from the FDA, I'm wondering if that complicates distribution because the distribution for them both is a little bit different. I know that they are, as Anjali was just describing, they are going to be distributing the vaccine a little bit differently using different processes, but wondering if that makes it broadly more difficult or if it makes it a little bit easier.
No, I'm going to suggest it makes it easier, actually. I think that, there's a lot of excitement. There's a lot of buzz at work. People are referring to when they get their text or their email saying they can schedule their vaccine. They're referring to it as their golden ticket. The Pfizer vaccines really did a good job of coordinating with hospitals, making sure that those vaccines were where they could be very quickly put into the arms of people that are staffing our ERs, our ICUs, our pulmonologists, really those critical people that need to be there. Moderna is going to be working with McKesson, which is a company that we all have a relationship in healthcare, really much more in the outpatient setting. So this is going to be a vaccine that a lot of us see going out to the primary care centers. So your primary care receptionists, your nurses, your support staff, your providers, as well as the urgent care doctors. A lot of these providers that treat that 80-90% of people that don't end up in the hospital. So we are super excited, and I think this has been really well thought through, and I think there's every reason to be positive about the distribution challenges.
Doctor, when I think about the vaccine distribution, I think one of the things I think of most is wariness about the vaccine from a lot of the American people. I'm wondering how doctors or public health officials can overcome that to really encourage folks to take this vaccine, because, I mean, the vaccine is really only as good as the amount of people that actually take it.
No, that's absolutely true. And we say that about everything. Every medicine we've come up with, if it sits there and doesn't actually end up either being taken by the person or the vaccine doesn't end up getting injected into a person, it's not going to protect them. One of the things we're seeing, and I refer to this as the Yelp review, it's one thing to hear the science is really good, but it's something else to see someone you trust, a physician, a nurse, a healthcare provider, get that vaccine and really endorse it with action. And that's what we're starting to see. And in all these surveys about hesitancy, the numbers of Americans that are excited about the vaccine seems to be rising very quickly. And I'm even seeing it now just in, well, it's only been about a day. And I'm already seeing sort of this excitement like, oh, you're signed up. I want to sign up. So I think that, if things continue to go the way they have, if the data and all the science and all the experience is what we've been seeing, I think, if anything, the demand for this vaccine will be higher than the demand for vaccines have ever been. So what do? We continue to communicate, we continue to be honest, and we share those experiences.
Doctor, I have about a minute left with you here. Wondering what you make of the news of lockdowns. It's a threat that we've heard, at least here in New York, especially in New York City after they shut down indoor dining. Now a warning that there could be a quote unquote pause in the city. I'm wondering if you think that is the right call to make, especially as we see the case counts continuing to rise, the death counts now crossing 300,000, hospitalizations increasing. Should we be getting a little bit more restrictive?
That's a fantastic question, and it is really tough. You look out there, and I have to say, it is worse right now in our country than it has ever been. We have more Americans in the hospital than ever. We have more Americans dying per day than ever. It is as bad as it's ever gotten. So this is really a time when people need to be careful. I know the holidays are here, Hanukkah right now, Christmas around the corner, New Year's, Kwanzaa. This is a time when people have to make smart decisions. I would much prefer if people made smart decisions instead of being forced to do those. But if we can't rein this in and the hospitals fill, and this is the way that we sort of regulate ICUs and ERs and hospitals, there are some potentially tough decisions ahead of us.
All right, Dr. Daniel Griffin, Pro-Health Infectious Disease Chief, thanks so much for joining us today with some of that sobering news.
Back to the pandemic front itself, we've heard from Fed Chair Jerome Powell a number of times this year talking about the full recovery not going to be taking place until the nation can get a handle on that. In terms of the vaccine progress we've seen there, it sounds like Moderna is still on the right track to see emergency use authorization for its vaccine to follow Pfizer's EUA as well, potentially as early as the end of the week here, which is welcome news considering progress needs to continue to reach the public here. With the beginning vaccine transmission here. We've already seen those shots administered across the country this week in terms of Pfizer's, but now reports from the New York Times saying that the Trump administration is working on building out more purchases of Pfizer's vaccine. Keep in mind, between Pfizer and Moderna, only about 150 million people could be covered by those vaccines by the end of June. That's about half the nation there, but more would need to come through from some other providers potentially to reach the numbers that we want to see. Joining us for more on that is our next guest here, Dr. Jeremy Faust is emergency medicine physician at Brigham and Women's Hospital, and he joins us once again here. Dr. Faust, good to be chatting with you again. I mean, when we walk through those numbers, we've seen the Trump administration want to push for more vaccines, questions around maybe passing on potentially locking up more of Pfizer's vaccine ahead of all this. Where do you put us in this phase we're at right now and potentially maybe boosting getting more than half the nation by the end of June?
Hey, Zach, good to be back. I think that the fact that the administration decided not to buy as much Pfizer vaccine as possible is a questionable one. I'm not an economist and I don't make business decisions, but my understanding of the whole concept behind Operation Warp Speed was to sort of hedge your bets and make sure that you didn't put all your eggs in one basket, but you bought as much as everything as you could. And basically the idea is any money you spent today on a vaccine, even on spec, would pay dividends down the road because it's a life saved, it's society getting back to normal. We can't, as you said, we cannot recover this economy with a sick population or people afraid to go out. And so the number one way to save lives and to save the economy is to beat this pandemic. And since it became abundantly clear that we would not be able to do so the way that, say, New Zealand is trying to do so with a complete suppression of the virus, since that became clear that we couldn't do that here, the way out has been a vaccine as far as I'm concerned. So the fact that we now have a vaccine that's being offered is huge, huge news for lives and for livelihoods. But the fact that we, again, as you said, aren't going to have enough vaccine doses until later this spring or early summer is disappointing. But I think that despite that, I think a lot of vaccinations will occur now that will actually make a difference.
Dr. Faust, you're in Massachusetts. Hospital capacity concerns certainly a growing concern there, along with so many other states. Last I checked, you're around 72%, so not as bad as some other states. But when you look at the uptick, what you're having to deal with in the hospital with more cases coming in, while also trying to inoculate those emergency workers, how are you finding that balance right now? Can you give us a little more insight on how it's playing out in your hospital?
In my region, in my hospital, we have absolutely seen an uptick in cases. There was a period of time, especially this summer, when we really had done a nice long shelter in place or stay at home advisory here in Massachusetts, and our caseloads were very low. Our mortality, we never got rid of mortality from COVID-19 in Massachusetts, but we got low. And we actually didn't even have excess mortality, which is more deaths than usual just from all causes. We had tons of excess mortality in our first wave, our first surge. But we had no excess mortality all summer and fall. And now, just now, the past week or two, maybe 3, we're now seeing more deaths than we normally would see at this time of year again. And frankly, more than we've seen in a long, long time. So we know that now we're not controlling the virus. And as you said, that sort of spells that the hospitals will become more and more full. Where I work, we have this incredible surge capacity, so we can expand our ICU capacities and we can expand our inpatient beds, and we've done that. If we did not have that ability, we would already be in deep trouble. So we're kind of ahead of it, but we can't really afford another huge surge and then also people's regular medical problems. One of the things that happened this spring was we didn't have elective surgeries. Well, now we're scaling that back again. People weren't coming in for other emergencies, or they weren't even happening. But not because, for example, car accidents just weren't occurring because nobody was driving. But now we're seeing our usual level of care, plus now COVID on the rise. And so that's what gives me pause for the next 8 to 12 weeks, is that we're coming into a time of year where the hospital's busy anyway, and now we're piling COVID onto it. And so, yeah, it could be that that next week I'm on with you, and I'm telling you that we're full. At the moment, we're okay, but it's tenuous.
Well, hopefully it stays, not full. But when we talk about it, it's another question around some of the things that you've been raising. Obviously, the next couple of months are going to be key here. But once you get past those into the vaccine front, big questions about whether or not people are going to actually want to get the vaccine. You've been pretty honest and outspoken about what to expect in terms of symptoms with your followers on Twitter. I recommend the follow, by the way, to our viewers out there, at Jeremy Faust on Twitter for a lot of this stuff. But when you've highlighted kind of those side effects and what to expect for people getting them, talk to me about expectations there in the willingness for Americans to line up and get this once it's available to, more than just frontline workers here, because as you've talked about, younger Americans may not have been the ones that have been stressed by the CDC, other health officials saying, look, do this for older populations, but you might not need to worry. Stats are kind of, highlighting some pretty serious risks for even younger Americans now when it comes to getting coronavirus. Talk to me about what your expectations are, particularly when it comes to younger Americans, to maybe be the ones that would want to come out and get themselves vaccinated once it's available.
It's really important. The younger population is the last group to be vaccinated. People in the under 65, under 55, and even 25 to 44, which is a group that I studied recently and we published today in the Journal of the American Medical Association. And my group, we found that there's actually this huge spike in mortality among young adults during the pandemic. And these are the people who are sort of last in line to get the vaccine. So now it's saying, look, A, this is more serious for people 25 to 44 than I ever realized before I started doing this work. And B, we're going to have to wait, unless you're a healthcare worker, to get the vaccine. So it's difficult to say, okay, we've come so far, and now we have a vaccine. Now, would you please wait for a few months and don't get it? But when you see the mortality figures, we had actually July was the most recent data that we looked at, but July was the deadliest month in modern American history for adults aged 25 to 44. Like 16,000 adults in that age group died. And the typical would be like 11 or 12,000. You never see higher than that. So for 16,000, and then the fall, it's been 15,000, 14,000, 15,000 again. So this is real. This is on the scale of an opioid crisis. It's on the scale of if motor vehicle collisions started spiking, if we had went back to a time without seatbelts. I mean, the scale is really impressive. It's not just statistical anomalies. So that's the really big thing. In terms of the side effects, yeah, the way I frame this is that it will cause side effects. The term that is being thrown around in the medical community is reactogenic. So it generates a reaction. And so it's meant to do that. And so we're sort of accepting the fact that we expect it to cause a fever, maybe in 1 in 5, 6 patients, headache, body aches. That's your body noticing that something's happening. And the way I frame it is not that it might happen, but it should probably happen. And if it doesn't happen, don't worry. The vaccine still is working for you, but it's expected to have side effects. And from the health care perspective, for example, I'm going to hopefully be vaccinated in the next week or so, but I better not be signed up to work the next day, because we don't want to be losing hospital capacity because doctors, nurses, and other healthcare professionals can't come to work. So there's a little bit of a timing issue as well. But overall, the top line is people ask me, is the vaccine safe? How do you think about it? And I am convinced across the board that with almost no exceptions, there are a few, but that getting the vaccine is far safer than getting the virus. It's not even a close call.
The first coronavirus vaccine shots were given this week, of course. That's the Pfizer-BioNTech version. The Moderna version might be on the cusp of being approved for emergency use as well. Our Anjali Kamlani is here. She just spoke to the Surgeon General Jerome Adams about the latest with the vaccine. Interesting, Anjali, we heard from Governor Ned Lamont of Connecticut at the top of the show, who said he thinks the federal government is handling the vaccine distribution much better than they handled things at the beginning of the pandemic.
Yeah, Julie, that seems to be a general consensus. There's been a lot of focus and a lot of effort. And early on, you actually heard some of those criticisms that the vaccine effort was getting way more attention than all the other parts of the response for the U.S. government. But to your point, the U.S. Surgeon General, we sat down and talked about a range of topics, starting with a new poll that came out from the Kaiser Foundation that said that 71% of Americans are willing to take the vaccine. Now that we know what the data is and now that there's been more information out there about these vaccines, there seems to be more willingness to uptake. In addition, the idea of whether or not employers can mandate a vaccine, while guidance currently says that they can, the Surgeon General advised against it. Let's listen to what he had to say.
The work is not done, but people should be excited. They should be optimistic. In the first surge, it was really about flattening the curve so that we didn't overwhelm our healthcare system. The second curve was about getting through the summer and really trying to save lives. This third surge, we now have a finish line in sight, and it's about running through to the tape. If you're getting to the end of a marathon and you can see the finish line, then it should give you the courage, the strength, the fortitude to keep on going. And I want people to know it's going to be a really hard next 3, 4, 5 weeks, because we've had record cases and those are going to continue to turn into hospitalizations and deaths. But that we have a finish line in sight, and we need to keep washing our hands, wearing masks, watching distances, and particularly during the holiday season, keeping gatherings small and smart, meaning within the people of your household, with the knowledge that once those loved ones can get a vaccine, we can have huge gatherings next year, and you better invite me.
Definitely. And looking at that, we know that, with the timeline, there's still so much more time before the average American gets to have a vaccine. Of course, that's because of the prioritization that the CDC has determined. But looking at it from that perspective, it still leaves a lot of time for people to continue to wonder, to maybe lose interest. So there's a lot of conversation, right, around the anti-vax individuals and messaging, as well as people looking up terms such as Bell's palsy and autism and the side effects of this vaccine. What's your message on that?
Well, my message is that it's okay to have questions. It's not okay. It is absolutely not okay to let misinformation and to let people spreading misinformation rule your life and cause you to make bad choices. You brought up some specific things, and I usually try to avoid lifting up myths, but I do want people to know it has been unequivocally proven that vaccines do not cause autism. When you hear about Bell's palsy, the incidence of Bell's palsy in the vaccinated group in the UK was the same as the incidence in the regular public. So it's not like this vaccine has any indication that it's going to cause any safety problems for anyone except for people who have a history of severe allergic reactions. And that's the case for any vaccine. If you have a severe allergic reaction, talk to your healthcare professional. One thing you can do right now is go to vaccines.gov or cdc.gov, and there are frequently asked questions on those sites about all sorts of vaccines. And you can also get your flu shot. Incredibly important right now when you're waiting for the COVID vaccine to get your flu shot this year, because you don't want to be taking up a bed that could be used to keep a COVID patient alive through next year. And that's a great opportunity to ask your provider, your doctor, your nurse, your pharmacist about vaccines and the COVID vaccine.
Absolutely. And talking about getting those shots, we know that companies have frequently been involved in flu vaccinations every year, making sure their employees get it. But with the COVID vaccine, there seems to be controversy over whether or not companies can mandate a vaccine before an employee returns to work. Do you have guidance on that?
Right now, we are not recommending that anyone mandate a vaccine. This vaccine hasn't been fully approved yet. It's been authorized, and that means that scientists, the FDA, and independent scientists feel that the benefit far outweighs the risk. what's interesting is you talked about vaccine confidence. One of the challenges is that vaccines are victims of their own success. Very few of your viewers know anyone who's ever been hospitalized for measles. They probably almost none of your viewers know someone who's been on a ventilator because they had polio and needed to be in what was called an iron lung. And so people don't see the benefits of vaccines. They only hear about the potential downsides. Well, guess what? This COVID vaccine is going to have clear benefits for people. And that's why you're hearing 70, 80% of people are saying they're interested, because they know it can protect them, protect their families, and help us get back to normal as soon as possible. So please, don't let misinformation and people out there spreading it rule your life. Get the facts yourself. And I think when people do, they're going to be just like me. I'm going to get the vaccine as soon as I am able to, as soon as my priority comes up, because I want to be an example for everyone else out there. I've seen the data. I know these vaccines are safe, and I know that they're 95% effective, which means that they can help us get back to normal.
I'm so glad you brought up taking the vaccine yourself. What is the administration looking at, and especially also the incoming administration, if you've had conversations with them about, handing off sort of this tactic and strategy, about how many influencers or celebrities can be brought in to the fold to take the vaccine publicly and enforce that message, just like you and others in the administration are willing to do?
Well, we aren't going to have vaccines for everybody right away. We're going to have enough to vaccinate 20 million people by December, 50 million people by January, and a total of 100 million people by February. So that's about half of the adult population. But that said, we want to immunize for impact right now. And that means older people, people in nursing homes and long-term care facilities. That's why we've emphasized those groups first. And then healthcare workers, because they're most likely to be exposed. Again, immunize for impact. And so the reason why I explain that is because we want to make sure influencers are getting the vaccine publicly so that it encourages other people to do so. But every person who gets the vaccine who's not in a high-risk group is potentially a person who is in a high-risk group who can't get it. So we are thinking very carefully, very intentionally about the risk-benefit ratio of getting certain people vaccinated out of their turn. And that's something that really deeply matters to me, because if I can encourage people to get vaccinated by getting it myself publicly, I absolutely want to do that. But the last thing I want to do is take a vaccine away from a vulnerable older person in a nursing home who would otherwise die if they didn't get it.
One of the things, and of course for you this also holds true, one of the things that's key is also getting the message out to the minority population. In the vaccine kickoff event at GW on Monday,
we must first acknowledge this real history of mistreatment and exploitation of minorities by the medical community and the government. Then we need to explain and demonstrate all that has been done to address these wrongs. So glad you brought that up. And that's why I keep saying it's okay to have questions, because there are some real harms that have been done to people of color in the past in the name of science by the government, by medical officials. The Tuskegee experiment, Henrietta Lacks, who got her cells taken without her permission. And so people rightly have some distrust based on what's happened historically.
So as you can hear, just the wide range of topics and that recommendation not to mandate the vaccine. So we'll see how things go as, we see more of the rollout of the vaccine and as we prepare for the general public. Julie?
Yes, most definitely. And a very strong message there, trying to reassure the public about the safety of this vaccine. Thank you so much, Anjali. Great interview.
We're going to invite into the stream Dr. Owais Durrani, emergency medicine resident physician at UT Health San Antonio. It's good to have you here, doctor. Wanted to ask you, before we get into the news about Moderna, FDA has approved a COVID rapid test. I think it's the first to get FDA approval. How important is this? It costs about $30 and you could do it at home. It's a COVID home rapid test that they approved.
Yeah, thanks for having me. It is a huge step. They'd actually approved one about a month or so ago, but it was prescription only. And so the big deal with this one is you can go get it over the counter or take it home. The other thing that we've been looking at is the false positives and negatives from the data that they looked at. And it looks like it's a pretty accurate test as well. And so this is going to be huge for those who need an answer in terms of, having some symptoms or an itchy throat or something like that, needing to know if they're positive and they need to isolate or if they can go about their day. So this is going to be, as it becomes more widely available, as it becomes more affordable, a huge kind of game-changing step moving forward.
Doctor, I want to ask you about the Moderna news that we got today. We could see the second vaccine here being shipped very soon. When we take a look at this timeline and how much this could potentially help getting a larger portion of the population vaccinated, what are you expecting for timing?
Yeah, so another day of good news in terms of the likely emergency use authorization approval later this week of this vaccine. It's going to be a major step in getting us out of this pandemic. It looks like we are on track to get 200 million doses of this Moderna vaccine in the upcoming months. So this is going to play a huge part in vaccinating those beyond the frontline healthcare workers and nursing home residents. It's going to play a huge part in kind of getting out to the general public. Much like the Pfizer vaccine, it's going to be a 2-dose regimen, mRNA-based, and spaced apart about 4 weeks or so. The other kind of interesting thing that I saw in the data was that it decreases by 67% asymptomatic infection. So, it's we need to see kind of how that trends out after the second dose. But that is positive news for those who were worried that, you might get the vaccine, you might be safe, but you might still be spreading it. Doesn't mean we can give up on the masks and social distancing right now, but it's good news moving forward. And it hopefully bodes well for the other vaccines when it comes to asymptomatic spread as well.
The headline today, though, in New York City is we're getting ready for another lockdown, perhaps around Christmas. I'm curious, when can we breathe a sigh of relief from all of this? What do you think?
Yeah, so, it's still going to be a while. It's still going to be, best guess, early summer, midsummer. Right now, all our metrics that we're looking at when it comes to positivity rates, ICU capacity, new cases, they're headed the wrong direction. Right now, even though we're getting all this good news about vaccines and we're getting vaccines into arms, right now our best defense is still going to be masks and avoiding big gatherings and following those basic public health measures that we've been talking about since late February, early March. Unless we make those changes and really abide by those things, we're going to continue to see numbers that are headed in the wrong direction for the upcoming few months. And so we really need to hunker down on those kind of basic principles.
Doctor, what are you seeing at your hospital, at UT Health San Antonio? How, just in terms of the virus spread, how out of control is it in Texas? Do you have a better handle on it than you did just around a month ago?
Yeah, so, we all kind of heard about the increase in Texas numbers. And about a month and a half ago, most of those numbers were coming from West Texas, El Paso, the tragedy kind of happening in the Texas Valley region. Now looking at our urban centers, so here in San Antonio, Houston, Austin, Dallas, positivity rates are going up and hospital capacity is dwindling. Our ICUs are starting to get more and more full. We're seeing ED boarding again, so patients that are admitted to the hospital staying down in the emergency department for extended periods of time because there's no beds upstairs. And that, studies have shown is not good for the overall care for those patients who need kind of that closely monitored environment and lots of nursing and physician care. And so, we really, really need to realize that even though we're getting this good news right now, we are in a much more dire situation than we were in the fall and in the spring, sorry. And in the spring, we were taking these massive kind of public health measures and closing indoor dining and things like that. And right now, most of the country isn't doing that. And so unless we really take a long, hard look at the policy changes we need to make, we're going to continue to see these bad numbers.
Do you know, did you get a vaccine yet? And do you know if you're going to get one if you haven't gotten the shot yet?
Yeah, I'm scheduled for 7 days from today. So super excited to get the vaccine and kind of be among the first to demonstrate that this is a safe vaccine, that it is shown to be effective based on the data. And so I'm truly looking forward to that in the next 7 days.
We wish you good health and good luck with the vaccine to you and your whole team. Thank you so much for joining us, Dr. Owais Durrani, emergency medicine resident physician at UT Health San Antonio. All the best to you.
According to the Johns Hopkins tracker, there are nearly 16.8 million cases of coronavirus in the United States right now, and the death toll has now surpassed 304,000. Let's turn now for the latest in this pandemic with Dr. Jesse Pelletier, president of Halodyne. Doctor, what kind of winter and Christmas season are you expecting now that vaccinations have started, and we might have a second vaccine, Moderna's vaccine, being rolled out soon?
Yeah, like you said, this wave of the pandemic has really spread across the United States and pushed our healthcare systems to the brink. Over 300,000 deceased in totality, 1,500 to 3,000 new deaths a day, over 100,000 hospitalizations, probably the darkest time since the influenza pandemic of 1918. We can contrast that, though, with the great hope and excitement of the Pfizer vaccine literally now being placed in people's arms, and the anticipation of the EUA from Moderna perhaps later this week. And what I'm hoping is that we'll eventually have a layered approach to vaccines, and that we'll start to develop some population-based immunity. However, there's still a very dark time ahead of us. And, I'm reminded of the Roman god Janus, whose depiction has one face forward and one face backwards, partly looking in the future, partly looking in the past, but present in a tumultuous time at hand here.
I didn't know I would be getting a Roman mythology lesson here today, Doctor, but I really do appreciate it. Speaking about looking forward, in your note, you said that we need to adjust to a new normal. What is that new normal as you're seeing it?
Yeah, I think that we need to, we're going to need to learn to live alongside this virus, that we need to learn to carry infection control with us through the end of this virus and as we see it moving forward, because most likely this virus will present itself as something that's endemic over time. And despite our best efforts at population-based immunity, will probably rear its head again in the fall. So doing basic things like, testing, tracing, and isolation, we can get into those strategies, but again, masks, social distancing, washing hands. We never thought that before this virus would be using alcohol-based sanitizers every hour, every 30 minutes, depending on what we do. And that's a new learned behavior. But there'll be other behaviors that we need to learn that might include also cleansing our nose and mouth before we place masks or don masks, similar to how we wash our hands before we place gloves. So the world will change significantly, and we'll have to change along with it.
So let's talk now about this vaccine. I'm wondering if you've received it yet, and what are some of your biggest concerns that you might have, if any?
Yeah, well, of course, it's a new construct. It's an mRNA construct. We haven't seen it before. It has not been FDA approved in vaccinations previously. And we just, we're trying to extrapolate information from about 44,000 patients into the arms of 10 to hundreds of millions of patients, right? So there are always concerns. We'll need more robust safety data over time. Currently, we're a little concerned about the reactogenicity of the virus, and that's a very normal response. Injection site redness, erythema, fevers, myalgia, body aches, all these things. We just want to really message to people that this is part of any type of vaccine and any vaccine construct, and they shouldn't, quote unquote, fear the needle, and they should feel comfortable coming back for their second dose. It's really a public health good that we all are vaccinated. Myself, I'm an ophthalmologist by practice. I also work in biopharma as well. So I'm not a first-line hospital healthcare worker in the ICU or anything like that. So I will be able to receive the vaccine in the next coming weeks, but currently am not able to.
I'm wondering if you think folks might be a little bit hesitant to receive that second shot, that second dose of the vaccine, especially as we continue to hear, these reports that some folks actually had some more severe reactions to the vaccine, fever, sweating, chills, soreness. I'm wondering if you think that might be off-putting.
It certainly could be off-putting, but we need to really message that that's normal, that's the way your innate immune system is really seeing the virus or seeing the vaccine and processing it. Now, in an mRNA vaccine, that could be a reaction to the nanolipid molecule that encapsulates the mRNA or to the mRNA itself. But depending on the construct or across all of constructs, you're going to see this reactogenicity, and that's normal. Now, we've seen patients with some anaphylaxis early on in the UK. And, we should, of course, warn those patients who are likely to be allergic that they should do this under the very close supervision of their physician or not at all at this time. But really, we need to message that it's normal and it's something that's overcome within the first 24 to 36 hours.
I only have a few more seconds left with you here, Doctor. I wonder if you had to look at your crystal ball, when do you think we can return to life as normal? Would it be next fall, next summer, next spring?
Yeah. So that's a difficult question. There will be a new normal that starts to develop perhaps middle to late of 2021. I think there's going to be a lot of fallout post-COVID of many issues, mental health issues, economical issues, sociological issues that we have yet to deal with. I don't think there'll be a real true normal until 2023, 2024.
All right, we're going to leave that there. Dr. Jesse Pelletier, president of Halodyne. Thanks so much for joining us today.
Thank you very much for having me.
Let's turn now to the continuing process of vaccination here in the United States. Of course, the first doses of the Pfizer-BioNTech vaccine were given this week, and now we are awaiting a potential approval of the Moderna vaccine. There's an advisory committee to the FDA that's due to give its decision later today. We could have the emergency use authorization awarded as soon as tomorrow, potentially. We're joined now by LJ Tan, Immunization Action Coalition Chief Strategy Officer. LJ, thank you so much for being here. Obviously, a lot of challenges with this deployment of the vaccines, both logistically, but also sort of sociologically and psychologically. And I know this is something that your group has focused on. How do you reassure the populace, particularly when it's such new vaccines, that they are indeed safe? Like, what does that campaign look like?
Thank you very much again for the opportunity to come and speak on this very important issue. I think, the biggest picture for all of us in the immunization arena, as well as public health, is obviously getting out of this pandemic. And getting out of this pandemic means we need to have herd immunity, which is going to be brought to us by the vaccine. So if we build the vaccine and nobody comes, that's a problem. So I think what the CDC has done, what my group has done, and a lot of public health advocates have done is work on this in twofold, right? The first thing, and actually the logistics of getting out the vaccine to the healthcare workers actually is probably the easier part of this process, is working with the healthcare workers to help them understand, and they're the ones that can understand the rigorous evidence that was looked at independently by the FDA and by the CDC's Advisory Committee on Immunization Practices, and help them understand that evidence was independently reviewed by independent experts to assure both safety as well as the efficacy of this vaccine, so that the healthcare providers themselves are now comfortable receiving it, because they are obviously in that first tier of recommended folks. Once they receive the vaccine and they're assured of the vaccine, their recommendation to their patients and to the public to get vaccinated will be the biggest and probably the most important reason why someone gets vaccinated. We know this from the past, that reluctant adults who were not interested in getting something like, let's say, the flu vaccine or the pneumococcal vaccine, after a great conversation with their provider, they end up getting vaccinated. So I think that's something we want to work on first as the healthcare provider. But that being said, the CDC is also launching a national campaign, and the Ad Council is also going to be launching one in a few months that's targeted at the nation itself, to help them also understand that this process of approving and authorizing these two vaccines are also evidence-based, science-based, resulting in a safe and effective vaccine that the public should feel comfortable taking. So, and I think we've been doing a lot of work on that over the last couple of months, and your statistics here would suggest this as well. And we've been seeing this incremental increase in not just public opinion with regards to whether they would get the vaccine, but also in healthcare providers as well. Healthcare providers have incrementally begun to come back and say, yes, we would get this vaccine as soon as it becomes available. So I think it's working. But again, as with any shift in public opinion, we've got to keep working at it and keep being transparent with the evidence, transparent with our knowledge, and transparent with our expertise.
And LJ, you're kind of outlining the challenge of
ensuring the process to get here was safe. But I'm curious about how you talk through the concerns people have with respect to side effects, especially when you're vaccinating tens of millions of people, hopefully tens of millions of people a week at some point in the not too distant future. The math says there will be thousands of people with, quite adverse reactions, but ultimately the math says that you, on average, are overwhelmingly likely to have a couple headaches and then be fine.
Yes, absolutely. So I think this is part of that evidence, sir. And I think one of the things we're looking at and telling people is this idea that side effects, is a bad terminology because it implies that there's something bad going on. And actually, a lot of the reactogenicity, which is what we like to use, first for the Pfizer vaccine, and then you'll see obviously from the FDA package with the Moderna vaccine, a lot of those systemic reactogenicity, like you said, the headache for a day or two, the fever for a day or two, those reactions are actually indicative of the immune response reacting to the vaccine. That's what we want. I think it's interesting if you look at the placebo and you see the lower reactogenicity, it's because they receive saline. The immune response is not reacting too much. And I think that's something we need to help people understand. It's a good sign that your body is getting the local soreness, because that means something's going on and your immune response is reacting. And the fact that you're getting this systemic fever for a couple of days, low-grade fever, that means the immune system is doing its job. So that's the first thing I think we need to help people understand. And the side effects are something we need to be very transparent with. This vaccine is reactive. We know that. And so if we want people to come back for their second dose after receiving their first dose, we have to be very clear about that, because sometimes you say, oh man, I got that first dose and it hurts. I'm not going to go get that second dose. And we do not want that happening. So we got to be very transparent. And then the second thing we've got to help people understand is that over the course of vaccinating millions and millions of people, we have the best vaccine safety surveillance system in the world here in the United States. And that this system will be looking at these millions of people getting vaccinated as we go forward in time. And these systems will pick up signal. And that's what we want them to do. Then the systems have to then do the job of making sure that the signals that we pick up are actually causally related to the vaccination process itself. And I think that's the job of the safety system. We've done this in the past with other vaccines. And I think we need to then be very transparent with that data, maybe monthly reporting out to the public to say, hey, look, this is what we're seeing now. This is what we're looking at. These may be causally associated. These definitely are not. I think that's the kind of messaging we're going to have to continue this vaccination program into 2021, into the summer and into the fall of next year, so that we can get out of this pandemic.
LJ, really interesting information and helpful information for people. Thank you for being here. LJ Tan is Immunization Action Coalition Chief Strategy Officer. Appreciate your time. Well,
Thank
when
you very
we come
much.
back.
Let's turn our attention now back to the coronavirus, because the U.S. reporting more than 3,400 deaths from the virus on Wednesday. That is another record. This coming even as hospitals and nursing facilities rush to vaccinate frontline workers for a third straight day. Meanwhile, we've got the FDA panel today beginning its review of Moderna's COVID vaccine. Let's bring in Dr. Patrice Harris. She is the CEO of EMED. And Doctor, it's good to talk to you today. I want to start by talking about the rollout of the vaccine for Pfizer, because there's some concern right now when you look at the Northeast, because of the storms, the ability to be able to vaccinate at the rate with which they need to be. And I'm curious if you have any visibility on that front, whether those conditions have hindered the vaccine rollout at all.
Well, thank you for having me back on. It's good to be on in my role as CEO of EMED. And certainly it's so important that we get vaccines in the arms of everyone. And clearly, as I thought about the storm, I knew that there may be challenges in logistics, but here's what I do know from the reports is that from the very beginning, companies and the government and states were talking about logistics. And so it's been reported that they have plans in place to address some of these issues. And there are going to be delays from time to time. We can't control everything, can't control the weather, but based on reports, there are plans to get these vaccines to the states so we can get everyone vaccinated.
And to your point about the logistical complications, it does seem like despite all of the concerns, even before the vaccine rolled out about the cold storage facilities being available and the ability to inoculate people in the way they need to be, the storm aside, things have been rolling out fairly smoothly. What have you observed so far, and where are you in the process right now?
Well, I have observed that. And of course, as a physician, I'm an interested bystander, particularly as an African-American physician. I want to make sure that I talk about the importance of getting this vaccine when it's your turn. I absolutely plan to get the vaccine when it's my turn. And so we will let the experts, the logistics experts, get the vaccines to the states. The states, of course, will determine the schedule. But again, we certainly need to get the vaccine into the arms of everyone who wants that. That being said, there's lots of promise around vaccines, but we know that we are going to likely not see everyone vaccinated until mid-June. And that's why it's so important for us to continue to do what we know works: masking, watching your distance. And a critical piece of the work that we continue to do is testing. And that's why I'm so excited about eMed. eMed saw a problem early on in this pandemic: long lines, people waiting days for results, having to drive to centers. And that, of course, would preclude anyone that didn't have a car. So looking at these barriers, including some of these social determinants of health, eMed saw that as a problem and certainly worked on a technology solution, sought out a partnership with Abbott. And that's why we are so glad, again, to be introducing eMed's digital point of care as a problem solver, making sure we get the tests to as many folks as possible, and tests that are affordable.
Yeah, Dr. Harris, I'm glad you mentioned all those pieces here too, because all of those have kind of been aspects as to why we've seen problems in communities of color. Not necessarily those are the only reasons here, but when we talk about testing and the problems there, you can talk about homeless populations. It seems to be an issue in California. I mean, just the numbers coming out of California right now, of course, we can get into vaccine down the pike and how that's going to be helpful later on. But just right now, 24% of the daily cases are coming from California, despite only having about 12% of the U.S. population there. We've talked about how communities of color right now in California, the Hispanic population, getting hit pretty hard here when we think about where cases are popping up. How much of that tends to stem from testing issues versus just what other, reasons as to why that might be happening right now, and how much of that needs to be emphasized when we think about rolling out the vaccines to some of these hard-hit populations?
We've seen that disproportionate burden on communities of color since the very beginning. And we've seen that regarding the burden of disease, and we saw that regarding the accessibility of tests. And so, again, as we look at all of these issues, we need to appreciate the disproportionate impact on vulnerable populations. And everyone needs to redouble, triple our efforts, do all that we can. There is no one size fits all solution, no panacea, but do all that we can to, as we say at eMed, democratize healthcare, make tests affordable, accessible. And this solution that we have in our partnership with Abbott brings that home. And again, it doesn't solve all problems, but clearly it solves a lot of the challenges regarding testing. And our solution is at home, end to end, from registration to taking the test. We have certified guides making sure that people do the test correctly. We want to make sure these tests are validated, right? And we want to make sure the results are validated. So a good process, a good result. And by the way, I take my test regularly. And here is an example of a completed test. And the other, I think, very critical piece of our solution at eMed is that we offer a digital certificate. And so once I get my negative results, I'm using my Face ID here. I don't know if you can see it. I'll try to hold it up to the camera, but I have a QR code here that shows my results. So we are very excited about, again, democratizing healthcare, doing all that we can to make sure that as many folks as possible have access to this test, but in the comfort of their home, in addition to the lines and the delays. Again, you get your results in 15 minutes here, but also going somewhere to get a test, risk spread of the disease. So all of these.
Dr. Harris, I want to jump in here because I think for all the talk about democratizing the test, I will tell you as somebody who's in California right now, where Zach pointed to, seeing huge surge, it is incredibly difficult to get a test at a very timely way. There are lines outside the clinics. There are those that don't cover specific insurances. People are waiting 2 hours line in some instances. And I'm wondering, for all the talk about testing, why we are still at that point right now, 8 months into the pandemic. I mean, is there something that you can point to that you think is not being done that could maybe allow for a little more efficient testing and encourage people to actually go out and get tested? Certainly people don't want to be waiting 2 hours in line if they want to get tested at a very frequent pace.
I agree. And that is our solution. That is our solution. You don't have to go anywhere. You can register through the Navica app, get your tests, get the test, the Abbott test, shipped to you, your home within 24 hours. And then you get online and are guided through that test by our proctor. You get your results in 15 minutes and you have a record of your results. So the problem that you just noted, the long lines and inability to get tests, that's a problem that we plan to solve. And we expect in Q1 next year to distribute 30 million tests. And so, again, that's a problem that EMED is committed to solve. We have this exclusive agreement with Abbott, but certainly going forward, we want to think about this with other tests and thinking about this globally.
No, it's very important. And to Akiko's point yesterday, I'm just very glad that I don't have to stand in those cold lines in New York anymore. At least that's one positive for people in California right now. But appreciate your time. Dr. Patrice Harris, EMED CEO, thanks again for joining us.